afternoon, everybody. I apologize for being a little bit late in starting. I also will let you know that my co-chair, Dr. Newton, is not here today. It's not that he didn't want to be here, but he is still a practicing physician. He is in charge of covering and making sure there's an emergency room doctor present. And apparently there's a little bit of a problem with that, and he just pulled an all-nighter and is due back to work very shortly once again in the ER. So he apologizes. He will watch it online, or he'll pull the tape and watch it. I'm starting to think of that if he can. So with that, let's get started. And Diane, you're going to start it off for us today. If you'll state so it goes out over the waves about who you are and who you're with.
I'm Diane Durrance. I'm the Women's Health Director for the Department of Public Health. Good afternoon, Madam Chair and committee members, and thank you for providing the opportunity for me to speak this afternoon about maternal health, women's health in Georgia, some of the initiatives we have in place, and some of the opportunities for moving forward. I want to start with just some brief information about the health of reproductive aged women in our state. In 2017, for women who were surveyed, or reproductive age women who were surveyed, reported weights consistent with obesity. That same year, about a quarter of the births occurred to women who were overweight prior to pregnancy, and 29% who were obese prior to pregnancy. For those same years, 2012 for the years we have completed maternal mortality review, 2012 through 2014, we know that almost half of all the pregnancy-related deaths were obese prior to pregnancy.
This is the one, the years 12, 13, and 14 when we had 101
pregnancy-related
deaths, and 45% of those women were obese.
Prior to pregnancy.
Prior to pregnancy.
Yes, ma'am.
What? And during the pregnancy? Going into the pregnancy.
Yes, going into the pregnancy.
Okay.
A survey of women who recently gave birth in 2017, only about 40% of those women reported having a healthy pregnancy weight prior to becoming pregnant. And you can see, like, over for a few years' time, that's a pretty consistent report. 16% of reproductive age women in the state in 2017 reported that they were current smokers. Smoking in pregnancy is a public health concern that has associated with adverse outcomes for both moms and infants. Women surveyed who had recently given birth, about 50% of them reported that drinking alcohol in the months before becoming pregnant, and about 6% reported consuming alcohol in the last 3 months of their pregnancy. Reproductive age women haven't been spared the impact of the opioid epidemic in our state. In 2017, nearly twice as many reproductive age women overdosed compared to a decade earlier. We've also seen the impact of maternal substance use in the increased rates of neonatal abstinence syndrome. Of those infants that were diagnosed with neonatal abstinence syndrome that had toxicology screening results, you can see the three most common substances that were identified: cannabis, stimulants, and opioids.
I guess when you're talking about cannabis, you're talking about THC.
Marijuana.
Marijuana. So because now they make it where it's CBD oil, but we're talking about smoking it. Okay.
Okay. And about a third of women surveyed in 2017 reported not seeing a doctor in the previous 12 months for a regular health checkup. And that's been pretty consistent in those survey findings for several years. I've listed the 5 leading causes of death. This is for years 2016 through 2018 among reproductive age women in the state. They include overdose, suicide, and homicide. In the first study committee meeting, there was information that was given in great detail about what constitutes a maternal death in our state. I won't go into this in any great detail, but just to review, it is the death to a woman during pregnancy or within a year of the end of pregnancy, regardless of the outcome of the pregnancy or the site of the pregnancy. So this would include women who died during pregnancy, who had given birth and died afterwards. Also, women who delivered a stillbirth, or had a miscarriage or an ectopic pregnancy. And passed away within a year of those occurrences. It is very important that we review all maternal deaths, those that are pregnancy related, to determine preventability, but also to get more information and learn more from our pregnancy associated but not related cases. Many of those we know through the maternal mortality review process do have some of those common causes that are listed in the previous slide: homicide, overdose, and suicide. And the more we know and the more information for prevention is very important. Just to recap, for the 3 years that review has been completed and findings published, there were 250 maternal deaths that met the definition of a maternal death that were fully abstracted and reviewed. Of those, 101 were determined to be pregnancy-related deaths. And of those pregnancy-related deaths, about 60% were determined to be preventable. I just wanted to put in the slide to remind about the leading causes, the 6 leading causes of pregnancy-related deaths for the years that we have published findings. Cardiomyopathy, the leading cause for those 3 years, followed very closely by hemorrhage and cardiovascular and coronary conditions. I'm going to be followed by 2 subject matter experts who's going to provide a lot more detail about some of those leading cardiac causes of death.
And I know that we don't have any years published that are sooner, but do you have somewhere in your talk? I think I asked you if you could give us an update on the more recent year of where we are.
I am.
Thank you very much.
Absolutely.
Okay.
Okay. In Georgia, we're really fortunate that many of our maternal health improvement efforts aren't operating in silos. As the state public health agency, DPH is uniquely positioned to be a point of coordination and collaboration for a lot of the statewide initiatives, coordination of a lot of the statewide initiatives that are ongoing. You can see some of them that I've listed out there and kind of how we're linked. Public health serves as that point of coordination to link a lot of partners and agencies together across all of these really important initiatives. The first I want to hit on is exactly what Representative Cooper just referred to, Maternal Mortality Review Committee. We do have case review completed and findings published for years 2012 through 2014. The committee has also completed review of 2015 cases that was completed in September. Findings from that review will be provided to you prior to the start of the next legislative session. I've just said that 2015 was just completed. Before long, it's going to be 2020. So I did want to provide some context about kind of what that means in Georgia and kind of where we started and kind of how we got here and what's coming next. We were actually, as a state, a bit ahead of the game in having a process for maternal mortality review. You heard Dr. Michael Lindsay speak at the first study committee meeting about his advocacy and efforts back as early as 2012 to establish a process for maternal mortality review in the state. And Dr. Lindsay, along with other partners, were a critical element to get that committee developed, get legislation in place to provide DPH with the authority to conduct review and protection for the review. You can see on the slides that we have set a very ambitious agenda for bringing case review current. The committee consists completely of volunteer subject matter experts that are dedicated to this work. They over the years and their development as a committee have increased in capacity and efficiency and are very committed to achieving this, the guidelines that we have set forth to complete the 2016 and 27 case reviews in the next calendar year, and the following year to complete 18 and 19 case reviews. That would bring us current with the goal of meeting the CDC recommendation for case review within 2 years of the date of a maternal death. One of the other things that's a really key thing that we need to have in place is a process for key informant interviews. We are currently trying to establish this to be part of what we have available for case review. So you heard in the first committee meeting, the lead abstractor for maternal mortality review talk about, how she receives files or records from provider practices, from coroners, emergency services, even law enforcement, and goes through those to compile a case summary for review by the committee. What we really need to know, though, is more context about individual women's lives. And talking to people that are close to her, that were close to her, that can tell us what were her barriers, what were things that could have made a difference, what was her support system like, to learn more about it. We find transportation issues commonly to be something that could be a consideration that needs to be, that there needs to be some process improvements for in the state. To learn more about that, especially in rural areas in women's lives, will be very important going forward. Another thing that came up, and Representative Stovall asked this question in the first committee meeting, and I don't think we really fully answered her question, was how did we communicate the findings out from the review process? And it's a very good question, and we need to do a better job, and we need to be more deliberate. I think we've gained in our ability to get the word out to OB providers in particular, but women need to hear the information and need to be aware of this information. Communities do. And we need to make sure that providers who are not OB providers, who see women actually for longer periods of time outside of that pregnancy window, are also aware of the findings.
One of the major responsibilities of this committee is to make suggestions for changes. Now, we can surmise that we need to improve in some places, and we know that transportation in a lot of areas is a problem, and that certainly could affect women getting prenatal care when they should get it, and a delay in prenatal care. So we can work on that. But if by providing bundles all over the state, all of a sudden we are having less mortality from hemorrhaging, but we have an uptick in another area, we're not going to know it for years with this reporting. And so we can't really pinpoint and really go after a major immediate cause of death. What is hindering when, I guess the CDC would get the death certificates timely. What is hindering us that keeps us this late in reporting? Do the hospitals not send you the information? Why are we not able, does the Maternal Mortality Review Committee only meet once a year? Or why can't we speed this up? What can we do to speed up the reporting and getting back the findings?
What we're doing to speed it up, we have to speed it up. We can't continue to operate in our shadow. We can't. We need to know more relevant, more data, and that's why we have set this ambitious kind of plan in place. So one of the things that we have to do, the committee has been meeting 4 times a year. We're going to increase that to 7 times in the next year. We'll add additional meetings if we need to get through that review process. We're going to expand the length of each one of those meeting days. It's a full day meeting going forward. So
it's not collecting
it's not collecting the data that's a problem. We are able to identify a case within the year of it occurring, and that's the recommendation. We can meet that. We've just got to catch our review process up with that.
Okay, thank you.
You're welcome.
Because we're looking for solutions and things that we can do to improve, our data collection and the information it gives us, but also we're looking for things that we can actually do to prevent both of them. But I think they're interconnected, so thank you.
Okay. Dr. Melissa Kotke in the first committee meeting did a very good job of talking about the Georgia Perinatal Quality Collaborative, which we consider one of our primary action arms off of the Maternal Mortality Review Committee to implement their recommendations. GAP-QC for short. She did a great job of talking about historically when it was established and all of the efforts that are going on. I'll just mention that the collaborative receives CDC funding. We have 3 years remaining of that funding. It's limited in what it provides. It provides for 1 full-time staff person and some operating cost. But that funding was critical as in a point of change for the collaborative. Prior to receiving funding 2 years ago, the collaborative existed, but it was difficult to implement any widespread initiatives. There was no designated lead agency, no real point of coordination, and the funding established that process and really kind of changed things for us. Everything that we're implementing now, though, is kind of like you mentioned, it's kind of acute care-based initiatives. They're hospital-based initiatives. They're very large and they're very robust. We're having great success with what we're doing, but we need to expand. We need perinatal quality improvement in outpatient provider settings. There's opportunities in emergency rooms to implement some things, and also in communities. We have largely volunteer physician leads and subject matter experts that are responsible for implementing many of the quality improvement initiatives. So we are currently looking at efforts to expand and sustain this effort to be able to implement more initiatives in different places where they're needed. I'll just briefly talk about GAP-QC hospital participation. Very robust participation from 62 birthing facilities in the state across 3 different initiatives. The hemorrhage initiative started in April of 2018. 44 hospitals are participating, and to tell you how this has exceeded our expectation, our goal in year 1 was to have 10 hospitals participate. Our goal for year 1 with hypertension was to have 5. We just implemented the hypertension initiative in June and have 36 hospitals participating. Neonatal abstinence syndrome quality improvement initiative was implemented in May, and 47 hospitals are participating. I do want to take just 1 second to highlight some rural health involvement in the GAP-QC. There was legislative allocation that became available in July of 2018 for rural hospitals to receive funding for perinatal quality improvement. It can be more challenging in smaller facilities with less human resources, to implement some of these quality improvements. That's where the real cost comes in, is in having staff time dedicated to making the change. 16 hospitals, rural hospitals, level 1 and level 2 facility participate. They're included in that 62 participating hospital number. All 16 are actively participating in the collaborative, and all 16 are implementing the hemorrhage initiative. 10 have begun work with hypertension, and 14 with neonatal abstinence prevention. And there are 9 of those 16 that are implementing all 3. I wanted to just list out the Alliance for Innovation on Maternal Health, AIM for short. Supported patient safety bundles. You can see a list of those available supported bundles. I've highlighted in bold the bundles that we currently participate in, that we're implementing. I've mentioned hemorrhage and hypertension, but also beginning in January, we'll begin to implement reduction of peripartum racial and ethnic disparities bundle. Measures from that bundle will be added to, are being added to both of our maternal initiatives for hemorrhage and hypertension. So when hospitals report their quarterly data and we track their process improvements over time, it will not only be for those hemorrhage and hypertension related measures, it will also include those that are related to disparity.
When you talk about that being in a bundle, what do you mean? How is that going to be different? What are you going to do to actually change that?
Okay. So I wanted to kind of talk about the bundle a
Okay.
little bit. Because I think when I think bundle, I think this big, huge thing. It sounds like a bundle. And so I'm going to look at break down just a couple of elements of what's included in the hemorrhage bundle, for example. So one of the requirements for all hospitals to implement the hemorrhage bundle is that they have to have a hemorrhage cart in place. And this can be a freestanding piece of equipment with drawers filled with all the required supplies, instruments, and medications needed to respond to maternal hemorrhage. But it's more than just buying a piece of equipment and filling the drawers with the things that you need. The labor-intensive part of this that is required is that there's also policy development, there's checklists, there's protocols for staff to follow, there's drills to practice readiness for use of the cart. The measures that we get back from the hospitals, as a first instance of how we measure their progress, we have 88% of the hospitals that participate in the hemorrhage bundle that now have a hemorrhage cart or carts in place in their facility, and that's a 50% increase in the last year and a half from when we started. Another example would be a process in place for quantitative blood loss. Is moving from estimating blood loss to actually having a process for measuring blood loss through a quantitative method is a requirement. We've also seen improvement in this. There are 70% of the participating hospitals that now have a process in place for quantitative blood loss assessment, and that's increased from 33 when the initiative began.
Okay, wait just a minute.
Oh, yes, please.
I got lights. Do you want me to have you answer your question now, Representative Hughley? No, it's okay.
Thank you, Madam Chair. I'm 23,
Got it.
just like my age.
Way to go, Carol.
Thank you. On your list of bundles, one that jumps out at me is the safe reduction of primary cesarean births. And that is not in bold, so does that mean we're not working on that, or?
We're not currently working on that. I'm not saying that that's not an important initiative to be considered, but it's one of the things when I mentioned earlier that we're doing these three things, and they're very large. There's a lot of moving parts to the three initiatives that we are implementing with our current resources. But there's a lot more areas that we need to do work in.
Dr. Ray, aren't the the OBGYNs, isn't that sort of a societal movement also to?
Yeah, outside of the bundle, this is I don't know if it's on or not. Outside of the bundle, there are hospital-based initiatives that are part and parcel of reducing the primary cesarean section rate just in general. So we track it. Hospitals are noted. This goes into the 5-star system for hospital accreditation, things like this. So they're outside of the bundle is just a piece, an education piece for the hospitals, but that initiative also is taking place on other fronts.
Right. That's what I
Just
thought,
there.
so it's not just what our public health department can do, but, because I thought that was a national initiative for hospitals
it
to
is.
reduce the number of C-sections. Although, did I just hear that there's also, Dr. Ray, don't go away, a movement toward physicians delivering a little bit earlier?
I'll only comment enough to say that there is evidence that has been presented, especially at subspecialty societies like the Society for Maternal Fetal Medicine, that does include delivering earlier, say 39 weeks, as opposed to the idea that the not performing the intervention, there may be some outcome improvement based on that. I think it's kind of early to
tell
make
whether it
policy
really
changes
is or
based
not.
on that, quite frankly.
I have one other, if you don't
Okay,
mind,
sorry,
Madam
Karen.
Chair. You were talking about the number of hospitals with Georgia PQC, and you were talking about the rural hospitals, and my concern is about the hospitals implementing the severe hypertension. How many of your rural hospitals are included in that?
Of the hospitals that there are 10 of the hospitals that receive funding that are implementing the hypertension bundle currently. It is expected that all 16 will do that. There are other rural hospitals that don't receive funding, that are considered rural, that don't receive funding, that are also implementing the hypertension bundle. And I can provide that information. I just couldn't give that number.
Okay,
Right
thank
now.
you. Thank you,
And,
Madam Chair.
I wanted to say too, in response to your first question about the C-sections, one of the reasons that we started where we did with the bundles that we selected was because of the leading causes of death identified through the maternal mortality review process, with hemorrhage and hypertensive related deaths being some of the leading causes. So that's why those were prioritized first.
In other words, you're triaging. I mean, which we're taught to do. You know, the first thing is to keep the patient alive, and then you can move on to
For other things that
other
need to,
other
yeah,
care. If you
other
just-
work
but
that
the main
needs to be
thing is
done.
don't let them hemorrhage to death or die from hypertension or the complications of hypertension, and then go forward. So that's the attitude. We did a triage.
Absolutely.
Okay, Representative Hughley. I got you. Stovall. I'm sorry.
Thank you, Madam Chair. I have a question on the slide that says GAPQC hospital participation.
Okay.
What is meant by neonatal abstinence syndrome?
It's infants that are diagnosed with having withdrawal symptoms related to maternal substance use.
I saw abstinence, so you know, I automatically thought it was something to deal with pregnancy, and I was like,
No, because obviously it hadn't worked if they're delivering. So, okay.
thank you.
Are you
You're
right?
welcome.
Go ahead, Deborah.
Thank you, Madam Chair. Thank you for coming today. I really appreciate it. Was just curious because I understand that y'all do have offices in every county in Georgia, and was just curious how much do y'all have the capacity to do any outreach with the schools at all to for so many of these to be preventable. To me is really where my question's going. You know, could we use Department of Public Health resources to leverage with the educational system and make sure that more people know that they shouldn't smoke or do drugs, or they should get checkups when they're pregnant? That seems like a really, really easy one.
I think it's an excellent question, and when I mentioned that, one of the things that one of the places that we're missing right now is at the community level, with schools being one a place that we'd want to target. But I think there's potential there for that.
I think that'd be
certainly.
great. The
Yeah.
question is, do you have enough resources to do that?
No, not at
No.
this time.
No. Okay. Thank
Right.
you. Thank you.
And I think that's one of the things, back to the communication that Representative Stovall mentioned, was, and then women who are affected, you know, through aren't aware that this is an issue in the state. So back to the need to get this out at earlier ages is very important. Put those prevention opportunities in place. Another thing that's
Wait,
part
wait.
of, I'm sorry.
I'm sorry, one more if I could. I apologize. If we don't have the resources, do we have resources at those offices for women to get checkups there? I know can they get checkups there, or they have to go to a federally qualified?
For checkups, do you mean?
I know you could get shots, for example, at the Department of Public Health in every county. Can you go and also get checkups, or?
There are at least, there's at least one location in every county that provides family planning services.
Okay, great.
And so
Okay.
that's physical assessment, obviously related to those services. There's also a pretty robust breast and cervical cancer screening
Okay.
program that's available in at least one location in the county.
That's good to know. Thank
But
you.
there's not, but they don't do, at least it's not widespread, if any of them do it, prenatal care, prenatal care and checking mothers as they go through the pregnancy. Is it?
It's not currently widespread. There are only about 8 health departments that have some type of service in place for prenatal care. But I am going to touch on that.
Okay, well,
Okay,
the
great.
opportunity
and I
there.
will say I've talked to Dr. Toomey, and it's one of the problems that we have. And and for people who don't know how it works, the state doesn't run the local public health departments, even though we give them money. In each of the public health counties, there is a county board. And the county board, even though it receives a great deal of funding from the state, or a significant amount, each county board runs what happens in their county public health facility. This does present a problem when we would like to see, everyone do prenatal care, and maybe the counties don't agree with us. I don't know. I hadn't gone out to counties on that one, but it is a problem. I know Dr. Toomey is working with not the boards, but with the people who directly, each
health
board
directors.
has a physician running that county, on that county public health. And so she is trying to work with them on the importance of getting more prenatal care and all. So she knows of it. Okay.
I think there's opportunities. Clinical simulation drills are another component of both hemorrhage and hypertension bundles. This is a very critical component to establish this process. We've had great success with the hospitals that are working on the hemorrhage initiative. 38 of the 44 do have a process that they're reporting on their quarterly reports now. And this just gives hospitals, especially those smaller facilities that may not see maternal emergencies as frequently, an ongoing process to have a scenario that they can follow, to have a simulation drill, to keep this kind of current and fresh on their mind with the processes that they follow during an emergency. And
I have a question. Is there something hanging over this cart that says if somebody's hemorrhaging, or something that does 1, 2, 3, so they're not flipping through a manual or anything, and they know? I mean, I'm sorry, but especially in the smaller hospitals where they don't deliver often, where they might go 2 or 3 years without ever, or maybe longer, without seeing a true delivery emergency.
There is.
Okay.
We have monthly webinars, technical assistance with these hospitals, and the hospitals participate very robustly in those monthly webinars. And that's exactly the kinds of things that are shared during those sessions. Hospitals share the tools that they've developed, like their checklist or their thing that's on the back of their badge that talks about what things weigh when they're dry, so they can do their quantitative blood loss assessment afterwards, kind of at a glance. But to make those materials available so you're not flipping through manuals and things like that, but to have ready access and directions in place. The debrief process is also important. So after a severe maternal morbidity event, and that's just an unexpected occurrence during the labor and delivery process that can have short-term and even long-term consequences on a woman's health. Things that like a hysterectomy, that would be an unexpected, but to have a very rapid debrief process after the event with all of the providers and staff that were involved, to go through a very specific, usually it's like a form of what worked, what could have been better, what things were missing, was the equipment down the hall, does the equipment need to be in every room, things like that to work through and to make the process better going forward. We do have Georgia's perinatal care system components are established to ensure that mothers and infants have access to risk-appropriate care. They include the regional perinatal care centers and now maternal and neonatal levels of care. There are 6 birthing regions in our state, and they all have at least one regional perinatal care center in each region. They're all level 3 facilities that can provide care to high-risk moms and infants. Each one of the regional perinatal care centers has a process in place for a plan in place for transport within their birthing region to ensure that high-risk moms and infants can be transported to a higher level facility when indicated, regardless of their ability to pay. There is DPH manages the contracts for the regional perinatal centers, and I say that just to say that it's so much more than contract management, because having that relationship with those contracts has established a great and much needed partnership between our staff, our Perinatal Quality Collaborative, and those regional perinatal center medical directors and outreach educators. We depend on them and their advocacy and partnership for a lot of the success we've had with GAP-QC, the outreach educator staff in particular. We have 2 perinatal regions that have 100% hospital participation in GAP-QC, and that's largely due to their advocacy and partnership. In July of 2018, legislation became effective to establish maternal and neonatal levels of care, providing DPH the authority to establish a voluntary process for designation of levels of care. We've worked through the rules and regs during the last fiscal year, and on November the 14th, next Thursday, the regulations will become effective and hospitals can begin to apply for designation. Once hospitals apply, they will receive a site survey and validation of compliance with the appropriate level of care. In July of this year, state funding became available to implement a perinatal psychiatric access program. The goal of this program is to increase the number of OB providers who screen pregnant and postpartum women for depression and anxiety. Also to increase the number of women who are referred or received appropriate treatment. Providers that participate in the access program, once development is complete, will have training made available that talks about the importance of screening, how to screen, when to screen. Also, they will have access to a women's health psychiatrist to help guide treatment and referral considerations. So we have all of those critical strategies in place or either in the process of being implemented, but we have opportunities to expand services to increase access to care, especially in rural parts of the state. 11 labor and delivery units have closed in the last 7 years. That's in addition to units that had closed prior to that time. All of those closures have resulted in parts of the state that don't have close access to a birthing facility. Closure of labor and delivery units also impacts OB providers' ability to practice in an area. In order to deliver, providers need access to a birthing facility, close proximity. So as a result of closures, OBs may leave areas to move to areas that are closer located to a birthing facility.
Representative Silcox has a question.
Thank you. Just curious, do you know why these places closed? Do you know the reason?
I couldn't speak to that.
No date on that at all?
I don't have.
Okay. Okay, thank you. Just curious.
Well, I think we can probably get it, but the ones that are closed across the state, if I'm correct, have been a variation of problems, some from mismanagement, some because their communities have dropped in population to where they can't support a hospital or a birthing center. I'm sure there are other reasons too, but the main reason is that we have a huge population shift across our state. People are moving out of rural areas into the metropolitan areas, and it takes about 45,000 people to support a full hospital, and we have counties in the state that all the surrounding counties have, 2,000 residents, 3,500 residents, 4,000 residents, and all the counties that they touch don't even come close to 45,000. So they can't support a hospital. And so it is a problem, but it's a problem that's occurring all over the country, especially in the states that had a high agriculture type of economy in rural areas where they grew a lot of things. The family farms are going, and people are leaving, and it's a sad thing to say.
According to the Georgia OBGYN Society, we currently have 80 counties in the state that don't have a local OB provider.
Okay, Representative Hughley, you had a question?
Madam Chair, I just to what you were saying, and another reason why the hospitals are closed is the way we reimburse for the services in this state. So they can't operate at a deficit. So that's part of the problem too.
And while we have those gaps, we do have resources to help bridge the gap to increase local access to care. In the state of Georgia, we have at least one health department location in every county, and we have an extensive telehealth network. We have the opportunity to utilize our local public health infrastructure and telehealth network to increase access in the rural parts of the state to prenatal and postpartum care. We have an opportunity to increase the number of certified nurse midwives and nurse practitioners that are available to provide routine care in those local rural areas through remote supervision of OB providers, through telemedicine. We also have an opportunity to increase access to maternal fetal medicine specialists through telemedicine in the state. There are parts of the state, depending on where women live, that can be more than 3 hours away from the closest maternal fetal medicine specialist. So that would be important to increase. This would also increase the ability, increase access for postpartum care. The College of Obstetrics and Gynecology estimates that as many as 40% of women don't return for a postpartum visit. We know from our 2012 through 14 maternal mortality review that of the pregnancy-related deaths, a majority of those occurred during that 6 weeks postpartum period and beyond. So that would be an important a component to increase access to the postpartum care. It would also increase capacity to provide contraception ongoing to women with chronic conditions. Hormonal contraception, that can be a barrier. We have an opportunity to increase access to group prenatal care in the state. We currently have there's about 17 group prenatal care programs in Georgia. There's been some barriers to expansion to sustain the programs. The component of group prenatal care that is demonstrated to have some impact not only on peer support, important peer support for women who participate, but some states and studies have published findings of decreases for preterm births and increased breastfeeding rates among women who participate. But we have not had reimbursement for the group component, the facilitated component in our state previously, and that has limited some of practices' ability to provide this additional service. We are very eagerly awaiting the outcome of the pilot that's currently underway at the Department of Community Health to hopefully expand opportunities for reimbursement for group prenatal care and be able to expand this service throughout the state in other locations.
Who's running the group prenatal care groups? Is it people from their communities that somebody's trained like?
So we have 3 group prenatal care programs that are based in public health, and those are run by the local public health department. The others will vary. Some of them are in, the others are largely associated with a private practice that would be led by those providers.
Okay.
And lastly, I just wanted to highlight case management. Increased case management during pregnancy and in the period beyond pregnancy is frequently recommended as an opportunity for prevention by the Maternal Mortality Review Committee. We have case management that exists in Georgia, but those efforts are largely siloed. And we do have an opportunity to be more collaborative and expand on case management that's available in Georgia.
Okay.
And I'll take any questions you have
Okay.
left.
Questions? Okay. Okay, Representative Hughley.
Thank you, Madam Chair. I want to make sure that I understood you correctly. You said there was a 40% failure rate in terms of women returning for their first follow-up visit. Is that what you said?
For their postpartum visit.
For their postpartum.
That's from the American College of Obstetrics and Gynecology. That's their estimate.
So that's the national rate.
That's,
And our rate is,
I
what
don't know.
do you expect it to be? In line with that or more than that?
I would expect it to be in line with that when you look at the number of counties we have that don't have a local OB provider. I wouldn't expect that our numbers would be much better.
And does that survey say
You wanna say
why? Why that is? Why they don't return? No?
Dr. Ray, do you want to?
I'll just make a comment that we've worked with the CMOs at looking at some of their data locally at the Medical College of Georgia at Augusta University, and some of that, the numbers are worse. And in large part, we do, based on the map that you see, have a real lack of outreach care for obstetrics there. So I think it really does depend on where you are and where you're getting the care. If you deliver an hour and a half away, they're not likely to come back for their postpartum visit. They have transportation issues a lot of times as well. So I think in pieces it may pan out to be like the national average, but in the evidence that I know for my own region, the East Central District, it's significantly worse than 40%.
Okay. And I think I saw a chart somewhere, and the more babies you have, the less likely you are to return.
Seems intuitive.
Right, that it
Unfortunately.
does. I think they went up to where they had 6 babies, and, at baby number 6, oh, well, who cares? Although I think that it might be more important that you return. Your bodies, after 6 babies, might be more likely to have problems, but I don't know.
Yeah.
I know more about OB than I ever wanted to know about OB, thanks to the study committee. So anyway, other questions? Now, I do have one question, all right? I asked, you say that 2015 is coming.
Mm-hmm.
All right, but are you finding pretty much the same number of deaths? I know this is not published and it's just an estimate. Are we still having, cardiovascular and cardiomyopathy? Is that right? And or cardio and hemorrhage about the same? Are the numbers sort of staying the same as they did the 3 years previous? Or are we having more hemorrhages? Are we having more cardiac problems in the 15?
We'll be able to tell you very soon.
You told me you were going to be able to do that today.
I tried. I really tried.
Okay.
All right.
I'm going to let you off the hook.
Thank you.
Okay. Who this is? Okay, Dr. Lundberg, go ahead.
Yes,
And-
hi. Welcome. Thank you for having me here. I'm welcome to be here. So I'm Gina Lundberg. I'm the cardiologist, the director of the Emory Women's Heart Center. I'm associate professor of medicine at Emory University. I started the first heart program for women in the state of Georgia in 1998. I've spent 20 years working with Northside Hospital, St. Joseph's Hospital, Piedmont, Wellstar. So I have a broad perspective of cardiovascular disease in women. We do believe that pregnancy is the first cardiovascular stress test that a woman goes through, and that is now part of our history and physical as well as our risk factors going forward. As pointed out earlier, we believe that 70% of the hemorrhage-related deaths and 68% of the cardiovascular-related deaths are preventable. The overwhelming cause of death in a woman is generally cardiovascular causes. Prenatal planning, pre-pregnancy planning is vital for controlling these and prevention. So you can't wait till the woman gets there for labor and delivery and try to have a big impact. It starts even months before she gets pregnant, prior to conception. These is data from 2018, and as you can see, hemorrhage and cardiovascular causes is the tied for first, and then tied for second is cardiomyopathy, and then preeclampsia and eclampsia are cardiovascular conditions. This is data from 2018 looking at blacks and whites. The whites are in the pink and the blacks are in the blue, and as you can see, they are different based on race. So while white women are overwhelmingly dying from hemorrhage and cardiovascular complications, African American women are dying of cardiomyopathy and hypertension-related deaths such as preeclampsia and eclampsia, and the mental health concerns are overwhelmingly in the white women. Pregnancy-related deaths, even back in 2011 and 2014, and of course that's the data you all just reviewed, shows the same thing with cardiovascular deaths being number one, hemorrhage, cardiomyopathy, cerebrovascular accidents, also contributing to the overall cardiovascular cause of death. Of concern, syncope is on the rise. Syncope is loss of consciousness, passing out, generally due to a drop in blood pressure and or heart rate. And we're seeing more and more hospitalizations for this from 2005 to 2014. Some of this may be increased reporting. So we are working very seriously, American College of Cardiology, the American Heart Association, and ACOG, the American College of Obstetrics and Gynecology, to get the word out that cardiovascular complications with a pregnancy portend to a future risk of cardiovascular disease, but also are the overwhelming causes of mortality during pregnancy. And they're basically hypertension-related disorders, high blood pressure that may have preceded the pregnancy or developed during the pregnancy, and then preeclampsia and eclampsia. Also preterm birth before 37 weeks, a baby that's small for gestational age, or gestational diabetes, which is suggested by a baby over 9 pounds, are all considered cardiovascular complications long-term. So this is put out by CardioSmart. It's the patient education program with the American Heart Association, getting the word out that pregnancy is your first stress test on the heart. And what we hope to do is get these women into primary care or cardiovascular care prior to the pregnancy and long-term after the pregnancy. We want to see all of these women following up with a primary care physician who will focus on blood pressure, cholesterol, diabetes, lifestyle management within 6 months of the delivery, and then follow them long-term. Pregnancy complications increase a woman's risk long-term of stroke, heart disease. It's associated with increased diabetes. So all of these things are going to be long-term cardiovascular risk throughout the life of this woman. The hypertensive disorders of pregnancy are overwhelmingly related to cardiovascular problems. Dramatically increased risk of hypertension after the pregnancy and long-term, as well as coronary artery disease. But importantly, all-cause death is increased 50%. Cardiovascular death is higher, heart failure increases 400%, arrhythmias such as supraventricular tachycardia and atrial fibrillation, and even an increased risk of stroke. So what we really need is a team working from preconception counseling, working together to get a healthy labor and delivery, and then post-term follow-up and long-term. We have to work with OBGYNs, maternal fetal specialists, obviously cardiologists, but we need pharmacists, nursing expertise, anesthesia, who knows what's going on at the time and prior to the delivery, and then social work to help address these social determinants that are limiting women, such as access to care, transportation, child care issues, and then we're seeing more and more women who don't want to follow up due to their concern about immigration issues. So hypertension during pregnancy is very important. There are physiologic changes that happen during pregnancy that are quite normal. Generally, the body has a lot more blood volume to deal with, blood for the baby and the placenta. And so we see a big increase in cardiac output and heart rate in a woman, but we see drop in blood pressure, decrease in systemic vascular resistance. And so fairly early on in the pregnancy, the woman's blood pressure may be lower, but as she gets closer to labor and delivery, it tends to get higher. And these are the manifestations of increased cardiac output that can predispose a woman to the hypertensive disorders, as well as cardiomyopathies and congestive heart failure. But also the woman has increased coagulability during this time. There's a lot of stress on the kidneys, the liver. It's really a total body effect from the pregnancy. There are markers that indicate a woman more likely to have pregnancy-induced hypertension, and again, this is why it comes back to the prenatal care. The obesity factor, which you saw earlier, is so prevalent in our women in Georgia, but previous hypertension, a previous gestational hypertension, a first-time pregnancy, but also a woman who's had multiple pregnancies, any pre-existing vascular disease, particularly something like fibromuscular dysplasia, even a family history of preeclampsia, collagen vascular disorders such as lupus, rheumatoid arthritis, psoriatic arthritis, possibly even Crohn's disease. These things predispose women to increased inflammation and cardiovascular disease. A woman having a child after age 40, possibly even after 35, and then pre-existing diabetes or renal disease. These are all factors that will lead a woman to have hypertension, and if she's already under primary care observation, prior to the pregnancy, these things are picked up more readily and treated more aggressively earlier. We do have algorithms for working with our OBGYN partners that ACOG and AHA have put together. This is just an example. I'm not going to read through the whole thing for you, but very simply, these things are okay. Lots of pregnant women have shortness of breath, palpitations, dizziness, but they shouldn't be having loss of consciousness. They shouldn't be so short of breath they can't get up and walk across the room. They shouldn't have syncope during exercise. They shouldn't have a resting heart rate over 120. So these things point out when a woman needs to be sent for primary care or, I believe even better, cardiovascular care. This is also part of the algorithm of when to determine a woman needs to have further testing. Some of these things can easily be done by the OBGYN, such as ordering an EKG or a BNP, that's a brain natriuretic peptide, and if the marker is elevated, it suggests the woman's starting to have early signs of heart failure. These are things that can be implemented with a nurse practitioner-driven or APP program, but also can be done, and then if there's a concern, they should be sent to cardiology. Generally, cardiology will start with an echocardiogram of the heart and obviously get good blood pressure control. Exercise is good during pregnancy, but a woman should not go beyond what she's been doing prior to the pregnancy. So a lot of times implementing lifestyle is too late during a pregnancy. The pregnancy-related complications that we do want to follow long-term are gestational diabetes, preeclampsia, and gestational hypertension and chronic hypertension. And again, this just shows the algorithm that they basically need to be getting back in with primary care very early after the delivery and followed long-term, and the goals for the long-term management. We'd like to see them get the baby weight off and establish normal numbers prior to another pregnancy. We also have guidelines in cardiology. We have guidelines for everything, but we have guidelines for hypertension during the pregnancy. When a woman's had previous hypertension-related pregnancies, we recommend the 81 milligram aspirin after the 12th week. We also have studies that show increased calcium supplementation can be helpful in a woman who's had previous preeclampsia, particularly if she has poor PO intake. We have routine medications we use. The maternal fetal specialist and the cardiologist work together. I work with an organization called Mother to Baby, and we're always working to find medications that are safe for the fetus as well as the mother. And the traditional drugs of methyldopa, labetalol, nifedipine, and even more currently, metoprolol are commonly used. Again, we want to see a woman within 6 months of her delivery if she's had a hypertension-related pregnancy. And we still want to start working at cardiovascular risk factors. The fact that pregnant women are still smoking is extremely concerning for the fetus as well as the mother. The obesity, these lifestyle issues could improve if we had better patient education and reinforcement that this is very important, not only for the next pregnancy, but for your long-term health for the rest of your life. Luckily, stroke does not happen a lot in pregnancy, but when a young woman has a stroke, it is more often related to pregnancy. The risk for stroke is higher in a pregnant woman with 34 in 100,000 versus a non-pregnant woman, 21 in 100,000. And the risk is markedly increased in the third trimester and postpartum. Again, that's most women who are going to have congestive heart failure, peripartum cardiomyopathy, risk of stroke. This happens after delivery frequently when they've gone home. Sudden spontaneous coronary artery dissection, or what we call SCAD, is completely related to pregnancy. So obviously it only happens in women. There are non-pregnancy related SCADs as well, but they seem to be a different animal. When SCAD presents in a woman, generally she does have EKG changes of the heart attack. We just have to work with our ERs to get an EKG on a woman complaining of chest pain, particularly if it's in the third trimester or early after delivery. These types of heart attacks tend to have more heart failure, have a lower ejection fraction, a poorer prognosis, and more commonly related to the left main disease, or what the lay people like to call the widowmaker. It happens in obviously younger women, and it's very strong, both of these in Caucasians. This is a diagram of pregnancy-related SCAD, and what it is you'll have a tear linearly into the coronary artery, not through it, and then bleeding with a hematoma into the blood vessel will limit the blood flow. Frequently that tear will open up to a flap, and then flow goes into it, and it becomes completely obstructed, and so it presents just like an acute MI. That's what we call an ST elevation MI. Easily detected if an EKG is performed. So I'm going to stop here because we have limited time, but prevention of heart disease starts with pre-pregnancy evaluation, careful attention to risk reduction, and then these women who have complicated pregnancies need long-term follow-up, not only to prevent maternal death in that first year, but to prevent cardiovascular death long-term. I just want to show you this one slide. This is the AHA statistical update for 2019. The women are in red. For years, we lagged behind with cardiovascular deaths, and we've done an excellent job with programs like Go Red for Women and Women Heart and HeartWise that increased education to the public about this as well as to physicians. But as you can see, from 2015 and 2016, we have an uptick both in men and women with maternal deaths, with cardiovascular deaths. And so we really have to start to implement this with our OBGYNs, working with women from 18 to 25, preventing obesity, following them long term if we want to have any long-term sustained reduction in cardiovascular deaths in this country in women.
I think we'll just turn you loose with a group of young women before they get pregnant and let you tell them all the things that can happen to them, and that might take care of a lot of people getting pregnant. So
Education is essential.
right. Representative Hughley.
Thank you, Madam Chair. I was just curious, with the increased use of vaping with our young people, what effect do you think it's going to have on what we're seeing here?
Nicotine is nicotine, whether you have a patch on your skin, you chew it, you vape it, you smoke it. Nicotine accelerates atherosclerosis. It's one of our most important risk factors because it's completely preventable, but it's also very deadly. When that's combined with other risk factors such as genetically high cholesterol or early signs of diabetes, gestational diabetes, it's even more aggressive. So we need to quit. I just spent Monday and Tuesday at Capitol Hill with the ACC legislation, and there's 4 bills before the House right now on changing tobacco laws, raising the age limit to 21, preventing advertising to the young people. I think it's extremely important in this country to minimize nicotine use in anyone under 21. Studies also show if you get to be 25 and you've never smoked, you're much less likely to smoke. But also we know that in this country, many people are smoking. I have a clinic in Hiawassee, and it is not unusual for them to tell me they started smoking when they were 11 years old.
Okay. Representative Stovall.
Thank you, Madam Chair. The question I have with some of the research that you all have done, what are some of the suggestions you even had when it came down to access to quality food? Because
Food deserts?
Yes,
It's a
because
huge
I know
problem.
when you look at some of the areas, even when we look at the map, and even the risk factors that you all have listed, a lot of it, and you talk about diet, and you talk about heart disease, all that still goes back to, having access to food. You might have more access to junk food than you do, the food, the healthier food. So what were some of the suggestions or things that you all might have come up with, or did you, was that a part that you all investigated into some suggestions on that part?
Well, lifestyle is the foundation of what we do to prevent cardiovascular disease, and access to healthy fruits and vegetables is essential. If all you have in your neighborhood is a McDonald's, then that's what you're going to eat. It is encouraging that a lot of places like Quick Trip or your gas stations are starting to have containers of fruits and vegetables, cheese, hummus, bananas, apples. The thing is, we still can't get people to buy them. So a lot of studies show that when you have the opportunity to get a salad or a hamburger, people still choose the hamburger. So we can't mandate what people are going to eat. We do need to increase access to healthy foods. But if you want to have a healthy pregnancy, start with a normal, healthy weight. Have good nutrition throughout your pregnancy. These things are essential. We're still promoting them.
I know that Mercer, in one of the clinics they did, they've encouraged a community farmers market and bringing in food, probably doing something like that do you have one down in your area too? Dr. Ray, I figured you did. And the medical students are going out and, talking to people and encouraging people to grow things for them. So I know that our medical schools are trying to get this across on healthy. On the uptick, do you think that was the uptick in the cardiac problems? are our unhealthy lifestyles catching up with us and starting that tick up
We think it's obesity related.
obesity, which is
Because not all obese people have health problems, but more obese people have diabetes,
Sure.
high cholesterol, hypertension.
right. That okay, who's it? Dr. Ray.
So, y- we talk about it all the time, and you talk about it as pervasive as this just health, being healthy before pregnancy, because pregnancy is not going to make you better. When specifically related to the disparity that we see between mortality and also in morbidity as it relates to cardiovascular disease between African American women and Caucasian women. Do you have some understanding? Obviously, it's complicated. Obviously, it's multifactorial, but do you see areas of prevention or areas of focus that, of course, we all should be thinking about as it relates to some way to narrow the disparity, whether there's some genetic factors that are at play, difficult and maybe impossible to overcome. But as it relates to other areas for potential prevention, where would you focus, or where would you tell us to focus our efforts and money and time?
So at the Emory Women's Heart Center, we have a project to screen 10,000 African American women in the Atlanta area, and we're collaborating with large churches and civic organizations to do this. We've already screened 1,000 women, and what we've learned is when we divide the women into 20 to 40, 40 to 60, and 60 and older categories, even the women 20 to 40 are already obese, meaning their BMI is already over 30. In that group, though, we don't see a lot of hypertension, high cholesterol, or diabetes. But when you look at the group 40 to 60 and 60 to above, they're the same. So the women aren't increasing with age. They go from somewhat healthy but obese at 20 to 40 to high blood pressure, high cholesterol, cholesterol, and diabetes, and the obesity from 40 on. We've got to get to women in high school, the probably 16 to 20-year-old woman, and talk to them about healthy lifestyle, exercise, diet. That would also be a great time to talk about birth control and contraception. But these long-term things will matter, and I think if we could get that 20 to 40-year-old group healthier, obviously that's when they're in their childbearing years, but we're also going to see fewer deaths from 40 and on. And one thing I didn't have time to show you here, because I can talk for hours, as you guys noticed, but this is a study that was just published in February, and this is looking at young women. This is the average age of 48, and the black women, as you can see, had more hypertension than the white women, the black men and the white men. They had more diabetes than the white women, the black men, and the white men, and they have more heart failure. In every category, they're higher risk. And the average age of these women was 48, and these are women having heart attacks from 2001 to 2009. So it's a crucial time period to get to these women younger, probably with high school, maybe even middle school education, and then follow them very closely in their 20s and 30s. And who's doing that? It's the OBGYN. So we have to keep working with our OBGYN community to have them do more primary or well woman care. I don't want to deliver babies and they don't want to do cholesterol, I understand, but we have to work together to take care of these women.
Well, if it's African American women that are the head on all these groups, I mean, there seems like when you look around everywhere, there's as many white women that are obese as there are African American women. So, I mean, the obesity factor doesn't seem to be. Is there some kind of a genetic factor that is anybody studying to see if I mean, besides all of the other things that can influence a lack of, getting the proper things, but
There's definitely some genetic influence because more African American women have high blood pressure as well, even the ones that are of more normal weight. So it's definitely got a genetic underpinning, but there's a cultural part to it too. So it's more than just genetics. We need education that's culturally appropriate for different groups. Like I showed you on the other slide, it's, white women have more mental illness and different causes of death than the African American women. So we don't have one pill that fits the whole community. We need to be diverse in our education, diverse in our solutions.
Well, I mean, why I asked was, it's like if there is a genetic possible reason for it, despite all the other causes, which are very valid, then we should know right off that we need to even work harder with that group in education and trying to solve all the problems, because they already have sort of a, not a mark against them, but they already have a predisposition to have a problem with it. So we ought to work even harder than we do in other areas. I mean, this is here again is triaging, and if you have one group that's more prone to have problems in this area, it's even more important that we educate and try to solve the problems surrounding that, like food island, deserts and all. At least it would seem like that to me.
You're absolutely right.
We need to work really hard on those. Thank you very much. I don't see any other questions from anybody. Okay, thank you so
All right,
much for
thank you,
coming
and
and
I
for
must
taking
leave.
care of women and people with cardiac disease. Thank you. Gina Price, Lumberg. No, who, wait a minute. Okay, I'm sorry. Sorry. Gina, no, Jamie Chosmer, sorry.
No,
Sorry.
I can't say that. I'm trying to close that. Sorry.
I hope it's not as long as this one.
That's not me. I just want to get out of it. Oh, there we go. Here. Awesome. You're so great. Thank you.
Okay. Okay, well, I don't want them to be, I mean, we started 10 minutes, we can go 10 minutes or more. But,
Trying to get us out by 3:15.
okay, but I don't want to cut short. We really need it.
So he said he taught her. Obviously, wants time for questions.
Okay.
Thank you. Okay. I'm Jamie Chosmer. I'm a nurse practitioner with cardiology at Northside Hospital with a special emphasis and focus with maternal cardiac disease. I'm also the clinical director of the Maternal Heart Health Clinic, which I started in 2014, which we are going to discuss in a little bit also why I started that clinic for these preeclamptic women. As we've discussed before and earlier, also it's an honor and privilege to be here, thank you. As we discussed earlier, maternal mortality rises in the U.S. as it declines everywhere else. This is a big problem. Some statistics that we've heard is from 2011 to 2015, about a third of deaths happened during pregnancy, a third happened at delivery or a week after, and a third happened 1 week to 1 year postpartum. 700 women die from pregnancy-related complications each year in the United States. 3 out of 5 of those could have been prevented. Over the last 3 decades, pregnancy-related deaths have more than doubled. The sad reality is that our country is the most dangerous country in the developed world in which to give birth. We already have talked about African Americans have the highest incidence, to kind of tail on what Dr. Lumberg said, perhaps genetics, environmental, having more comorbidities. The leading causes of death in Georgia from 2012 to 2014 include preeclampsia, cardiomyopathy, cardiovascular diseases, hemorrhage, amniotic fluid embolism, and pulmonary embolism. Today I'm going to discuss with you preeclampsia and cardiomyopathy and those effects for long-term health. So first, to discuss what preeclampsia is, it's a disorder that only occurs in pregnancy and in postpartum. It occurs in 3 to 8% of births and affects the mother and the unborn baby. Usually we see this after 20 weeks. What happens is it's a rapidly progressive condition characterized by high blood pressure, plus or minus protein in the urine. You can also see elevated liver function tests, reduced kidney function, fluid in your lungs, visual changes, headaches, and decreased platelets, which are a part of your blood count. What do we see from these women? What are they complaining of? They're complaining of bloating, shortness of breath, headache, anxiety, weight gain, visual changes, and abdominal pain. What exactly can cause preeclampsia? Well, its theories to be insufficient blood flow to the placenta is one. Excessive inflammatory response to pregnancy. We already said that pregnancy is kind of a stress test on your body with the increased cardiovascular output and everything that kind of occurs. So what happens is we feel that this is actually all an inflammatory response. Nutritional deficiencies, disruption and balance of hormones, genetic causes, and injury to blood vessels due to excessive flow. As discussed earlier, some risk factors for preeclampsia include African American, fertility treatments, and that is thought to be secondary to the hormonal influences, having multiples, first-time pregnancy, if you have a change in paternity, age greater than 35, history of preeclampsia with your past pregnancies, chronic hypertension, diabetes, kidney disease, history of coronary artery disease, family history of preeclampsia in your aunts, your sisters, or your mother, polycystic ovarian syndrome, autoimmune disorders such as Crohn's disease, colitis, psoriatic arthritis, rheumatoid arthritis, as Dr. Lundberg said earlier, and the big factor of obesity. So where does coronary disease tie into this? Well, earlier we discussed that one of the risk factors one of the causes of preeclampsia was the inflammatory response. Well, as we know, what is coronary disease? It's inflammation. It's a problem with our lining. It's the inside of our body that's causing us to have plaque buildup and then eventually having hardening of the arteries. What we know is that preeclampsia patients have 3 to 4 times the risk of developing hypertension and 2 times the risk for having heart disease and stroke, and an increased risk of diabetes. We usually see these changes where you can start seeing the high blood pressure in these women about 5 to 15 years postpartum. Normally, women have heart disease later on in life than in men. Usually men around 55, women around 65. When somebody has a history of having preeclampsia, we bring actually the women's risk down by 10 years, and so our risks are about 55. As you can see, older mothers would certainly be at an increased risk of developing heart disease if they had preeclampsia with that delivery in their 40s versus when they're in their 20s, because they're closer to that age range. Some women have to be on medication just for a short period of time. A lot of times by 6 weeks, they're off of their blood pressure medications, but there are a lot who still now just unfortunately have hypertension as a result and have to be on it for life. In 2011, the American Heart Association identified women with history of preeclampsia at risk for coronary artery disease. That was huge for cardiology, because now you're saying that preeclamptics have the exact same risk factors as someone who has diabetes. What we need is to have a yearly check of blood pressure, cholesterol, and blood sugar. So what did I do about this? Well, in 2014, I started the Maternal Heart Health Clinic at Northside Hospital. Northside Hospital does about 17,000 deliveries a year. This is a huge amount of deliveries, more than some see anywhere. Why I started this is I had preeclampsia with both of my children, and I also had congenital heart defect when I was born, and I had surgery to correct that. So we need to educate and let people know that this is something that's real and that we can help take care of these 17,000 people who were delivered. Not all of them have preeclampsia, but quite a few can. What I figured is new mothers often focus on caring for their children instead of themselves. What my clinic does is it shifts the emphasis back to the mother taking care of herself so she can in turn be there for her family in the long term. So how this clinic is devised, it's actually referrals straight from the hospital. A woman delivers, and there's certain categories that I have. If they had a history of having severe preeclampsia, they had a history of preeclampsia with their other deliveries, if they delivered before 34 weeks, if they had eclampsia, or if they had to go on a medication called magnesium, which is a medicine if someone's blood pressure is very high during delivery to prevent them from having a seizure and then going on eclampsia. So those are kind of my criteria. This is in all of Northside hospitals. It's just ran. You click on the chart, or you will fax something to my office, and my scheduler will get these women in. I will see women at any time. I see people from the community. They don't have to deliver at Northside Hospital. There's apparently a Facebook group for women with preeclampsia, and that's how I get actually referrals. I didn't even know about that until a patient told me that. I thought that was wonderful. So that's great for the community, and I will see them anywhere from any time they had that delivery. I don't care if you had your child 30 years ago, 40 years ago, you are at risk. I will see you, and we're going to discuss everything you need to know. So they meet with an exercise physiologist who's first going to discuss the importance of exercise. One of the things that we talked a lot about is obesity. Yes, genetics play a role. We've talked about that, absolutely. So does what we eat. Obviously, the best thing is we have to eat less and move more. If we don't change our eating, if we change our eating habits, but we're not exercising, we don't really help out much. We really all need to get moving. New mothers are great because they can incorporate their children. Babies love to be rocked. Babies love to be walked. I always say, if you have a good pair of shoes, that is all you need to exercise. You don't need to spend money at a gym. You can take your baby and you can do squats at your house. I don't care what you do. These women need to start being more active. If you are more active, you will lower your risk of having heart disease just based on that. We also promote 10,000 steps. Every cell phone or Fitbit or what have you, Apple Watch will have information on how many steps you walk and what have you on those apps too. So that's a great way to get to see what your steps are. They'll also meet with a nutritionist from our hospital who will go over exactly really what they should be eating, what they shouldn't eat. They do also talk about just what your patient is eating. Unfortunately, a lot of them are just not eating enough, and they're not going to be healthy for their baby. If they're breastfeeding, they're not eating enough calories in, and they're just not healthy. Being healthy doesn't just mean being a certain size. You have to also have the proper nutrition and exercise and kind of the whole gamut. And then you meet with me, and I put everything together. I explain exactly what preeclampsia is. We pinpoint why you might have gotten preeclampsia. I go over all your risk factors. Then we discuss future pregnancies, things that we can do to prevent this or try and reduce your risk, actually not prevent, reduce your risk. Again, start your next pregnancy at your ideal body weight, keep being active. And then I discuss that what we really need to do is we need to prepare now for what happens in the future. It's very difficult when I get 17-year-olds, 18-year-olds in my clinic, and I try to explain to them about the coronary disease that they can get in their 40s and their 50s, but I explain to them really the role and why it's so important that they are in that amazing time where they really can make a difference. As we said, talking to the younger mothers, talking to the 16-year-olds and 20-year-olds before they get pregnant to let them see the importance of what can happen later on in life. Well, these women have already had a baby, so I say, okay, listen, you had preeclampsia, you have risk factors, but we totally can change everything just by what we do. And then what I do also is we'll have follow-up for those at the highest risk. What we do is obviously I do general cardiology, so then we can shift them into my clinic or with one of our physicians. So we have follow-up so we can monitor these women long-term and also with their subsequent pregnancies. I'm currently trying to work on phase 2 right now, which is to see these women again about a year postpartum, follow up on their cholesterol, their blood sugar, see where they're at, see if they've made any changes. I do have a big database with regards to this. It's just unfortunately I'm the only person who's doing this, and I also, as all of us do, wear many hats and have a full-time, also the cardiology. I'm going to switch really quickly to the next topic, which is really a big number one killer of women in this period is postpartum cardiomyopathy. What is postpartum cardiomyopathy? It's a weakened heart muscle that occurs between the last month and 6 months postpartum. Cardio obviously means heart. Myopathy means weakened heart. The heart doesn't squeeze forcefully enough to pump adequate amounts of blood flow to the body's organs. What happens obviously is that the fluid doesn't have anywhere else to go, so it starts to increase, and it can go to your lungs, it can go to your abdomen, it can go to your legs. And these women come in extremely, extremely short of breath, and we'll talk about that in just a second. What it does is it puts these women at increased risk for abnormal heart rhythms, blood clots, and sudden cardiac death. What do we think maybe causes this? We're not sure. It's potentially inflammatory, maybe genetic. There's a 20% correlation between that. Also thought to be an exaggerated immune response to pregnancy. And we know that African American, preeclamptics, those pregnant with twins, and age greater than 35 are at the highest risk. Take a look at these symptoms. Well, shortness of breath with activity, swelling ankles, bloated, fatigue, feeling your heartbeat, decreased activity tolerance. Well, those symptoms look just like pregnancy, right? They're also the same symptoms that a woman can have when they have heart failure. So you can see a lot of times on how these can be dismissed. Unfortunately, I had a patient actually that I was taking care of today she was a 35-year-old African-American female who delivered at a different, she delivered at the hospital, was sent home, called her OB with complaints of having everything, and she's postpartum, and they said, oh, just keep an eye on it. She said, I'm 35 years old, I'm African American, I had gestational diabetes, I have a lot of risk factors, I'm calling back because this is not right. Well, she was right, and she came into the hospital, and I saw her this morning in consultation, told her I was very happy that she did take the healthcare into her own hands, and she does have fluid overload, and we're working with her, and she will be okay. But thank goodness that she came in. But it was pretty interesting that the exact word she said to me is, I'm a 35-year-old African American with gestational diabetes. They didn't take me seriously at first, and so I called back. And I said, good for you. And I just was like, wow, I'm going today to discuss this exact thing, so I'm really proud of her. What can we do and what are we doing at Northside already? Well, we actually have a heart failure clinic in place. This is also for general cardiology, but we expanded and had all of my postpartum cardiomyopathy patients follow up in there as well. They have biweekly visits to a heart failure clinic. This is ran by nurse practitioners. And what they do is they adjust medications, they check laboratories, and they have lots and lots of patient education. They monitor the patient's weight. You should be losing weight. And they talk about diet, also medications, as I said. And the purpose of this is to reduce hospital readmissions, which is obviously, as we know, a huge problem that we have. Why do we think we have reasons for increased mortality? Well, unfortunately, it's manyfold. New mothers are a lot older than they used to be. We're having patients in their 50s and they're 55. There was somebody at Northside who was 61 who was pregnant. This is because of fertility treatments, unfortunately. Well, your 60-year-old mom, your 50-year-old mom, they have a lot more comorbidities than somebody in their 20s. So unfortunately, this is a huge problem. Half of our pregnancy in the United States are unplanned, so many women don't address chronic health issues beforehand. Kind of the prenatal care also plays a big role in here. We have a lot of patients who have no prenatal care. They come into the hospital they come into Northside, they're transferred from outside facilities, and they're basically look like a train wreck. They have every comorbidity, and you're like, oh my gosh, okay, we got to get to work. We have a short amount of time to get everything safe and get this woman safe delivery, and just make a huge impact on her life. Access to healthcare. Many live in rural areas and limited to no resources, as we talked about earlier. Missed or delayed diagnosis, not recognizing the warning signs. If patients were obese before pregnancy, and outdated notions that delivery cures all. A lot of people think, once I have the baby, there's nothing wrong with me. I'm okay. That's a big misconception with preeclampsia. As a ton of my patients say, wow, I just thought delivery was the key, and I thought my blood pressure was going to go back to normal. I had preeclampsia beforehand with my daughter before I delivered, but with my son, I had preeclampsia after. Clearly, that's not the case. So what can be done? Well, during pregnancy, we need to all improve access to and delivery of quality prenatal care, including managing chronic conditions, hypertension, diabetes, high cholesterol, and then educate these women on the warning signs. At delivery, we need to standardize patient care, deliver high-risk patients where appropriate staff are. If a patient's in a rural area, let's try and get them to a facility where they have a lot more deliveries and a lot more experience, so these women are not dying from all these other conditions that you'll talk about later on today as well. And then postpartum, we really need to provide care for at least up to a year postpartum. Unfortunately, right now, this is not happening. As Dr. Lundberg said, we see how many people showed up for the postpartum visit. That's a really good time in order for healthcare providers to see and to manage and see really what's going on. A lot of times patients will come back into my clinic and I'm like, whoa, your blood pressure's through the roof. Have you even followed up with anyone? No, they haven't. And obviously communication with staff, patients, other healthcare individuals also. So what can we do? Well, community outreach, health fairs. I've done several health fairs where I talk on maternal health, and I get referrals also to my clinic based on the health fairs. I want to start getting into churches and temples and other areas that they'll have me. One thing when we spoke about also is going to Babies R Us before it kind of went out of business, and they have a lot of mothers forums and what have you, and for us going out and kind of educating to the public about really what needs to be done. Educational meetings with multidisciplinary teams. I do all the education for the nurses and to let them know really what this all means, and for them to also discuss with their patients. We need to also discuss telemed for rural areas. I do think that is a great area for us to expand on. Obviously, as was said earlier, 3 hours away might be your nearest high-risk OB, cardiology team, etc. If we could have something where we could get these questions easier and have these patients then triage better, I do think that is something that we really can do. I would love to expand this postpartum period. Medicaid only covers for 60 days. Well, that's huge. As we talked about earlier, 55% of women in Georgia died within 42 days postpartum. Okay, well, 42 days from 60 days. You do the math. It might take time for symptoms to occur, and then it's also going to take time to get into their healthcare provider's office to make an appointment. Maybe they don't have childcare, maybe they don't have a ride, maybe they don't have a car. So we've now missed this window. We've missed 60 days. They're not going to show up. There's no Medicaid. Oh my gosh, what are we going to do? Not good. The CMQCC is a model from California. It's called the California Maternal Quality Care Collaborative. This was developed in 2006 in California, and what their aim was to improve healthcare response to the leading cause of preventable death among pregnant and postpartum women. I'm sorry. What I really think needs to happen is I think every state needs to really adapt and listen to the CMQCC. What they do is and it's free. You log on and there's toolkits. What it basically does is if you have there's toolkits on hemorrhage, there's toolkits on hypertension, preeclampsia, many other cardiovascular issues and many other pregnancy-related problems that can occur. And you just literally click and it has an entire thing and it's going to actually tell you. It's like an algorithm. If you notice that your pregnant woman's vital signs are X, you need to do this, you need to do that. It's such an easy thing. If you can read just any part, then it is so easy just to really try and stop and have things happen. You can really prevent them before they start. What we know is that limited awareness results in missed opportunities for early recognition of women who are at increased risk of problems later in life. Changes we make today can have an impact for a healthier tomorrow.
Okay, thank you. Let me make one thing perfectly clear. I am asking for an extension of Medicaid. On Tuesday, I had a meeting here for something else, and the head of Medicaid was here, and the governor's person on health, and we had a discussion about it. Every time I see them, we have a discussion about it. I guess hopefully they're just going to get tired and give it to me.
Perfect.
Because I am going to keep it up until hopefully I get something. It may not be a year, but if I want a year, I'm asking for a year. So just know that somebody's working on that.
Excellent.
And like I say, I'm going to keep on bothering them until we do that. I can tell that you're passionate about your patient care. I always say nurses are great teachers, spoken from a nurse with an advanced degree. And that is one of our strengths is patient education. So thank you for that. You have questions. Representative Stovall.
Thank you, Madam Chair, and thank you for your presentation. I do have a question. When you talked about the incident that happened with a 35-year-old African-American woman, I instantly started thinking about, and I saw where you're doing educational meetings. So I want to know, is that one of the things that you are actually talking to the nurses and the physicians about, not having a bias when it comes to race? And also the patients, like you told that young lady that was good that she was able to speak up for herself. But a lot of times when patients, the doctor tell them, because the doctors are the experts, and when they tell them, oh, okay, don't worry about it, go home, unless they really are educated and really feel that something is going on with their body. But most of the time they won't come back. And so I think that there's a level of commitment or responsibility on the physicians and the nurses that are seeing these patients, especially we keep seeing that it's African-American women in a certain, age range and other complications that are happening.
Great question. Absolutely. Yes, I do. I lecture, like I said, for the nurses at the hospital, and I tell them, we see no color. We are not allowed to see color. Do not. Every patient is the exact same. I want you to take this person's complaint. Everything's the same. Just shut your eyes and listen, because we really, really, really need to stop it. I lecture for the Emory nurse practitioner students also in certain programs, and one of the things I discuss also is race, and had a wonderful question from one of the students saying, like, what all can we do? Well, I really think we just need to get rid of our bias. Now, I know that our life would be a lot easier if we could do that. I say, listen, everybody's a person. Yes, we all have risk factors. Yes, we can all change it. One question is, well, why is African Americans, why are they the highest risk for everything? Unfortunately, it's just we see a higher risk of hypertension. We see a higher risk of diabetes. We see a higher risk of certain other things. But like Dr. Lundberg said, your white women have have other things. So we need to just eradicate, get rid of it, teach people that it doesn't matter. Just because they have an increased incidence of it doesn't mean that we don't need to teach it. We still need to 100% explain to women that women are women. We see no color, we see no race, we see nothing. We just need to take care of the female.
Well, I mean, I think I'd have to disagree with you on that. I'm sorry, from one nurse to another, because if we know, when you say everybody's just alike, they're not. And if you are working with OB patients and you know that African Americans have a higher risk of something that's related to hypertension, that ought to be an alarm system to you when an African American lady calls in and says, I'm a certain age, and I'm having these symptoms. Whereas for a Caucasian lady, it might be another risk. I mean, I'm sorry. I just believe in having alarm bells for certain things are really bad. That's my bias. Dr. Ray? And if you can make your answer as short as possible.
So I, in a specialized care model where we, the obstetrician gynecologist is often providing care that's perhaps outside of their scope, especially related to psychiatry and cardiovascular disease care. There is, my question would be, is there a financial incentive for those who specialize in cardiology to actually see patients who have perhaps preeclampsia in the postpartum period? Much of what we do it as I'm an obstetrician gynecologist, so much of what we do is specifically bundled into the care, and so postpartum care is also in that bundle. If I refer a patient to a cardiologist for because they've had severe preeclampsia and require additional tinkering with their blood pressure medicine, for example, is there some financial incentive for this? Is it billed as a routine E&M code, or is it bundled? Can you answer that?
Absolutely. So one of the cardiologists I work with is passionate about maternal cardiac, and we see tons and tons of referrals just for this. We see women when they're pregnant with hypertension. We see patients postpartum and take care of this. We don't get any financial incentives. It's just a normal billable code. Obviously, you get paid for it. But yes, absolutely, a cardiologist is the perfect person to send somebody like this to.
But it is paid outside the bundle.
Mm-hmm.
Okay.
Thank you.
Doctor, you going to introduce him?
Yes, happy to.
And we are going to run over our time, and I want you to have enough time to where you feel like you can do your presentation without being rushed through it.
Great. So I'm Matt Hicks with Grady Health System, Chief Policy Officer, and wanted to introduce to you Dr. Diogo Housen, who is one of our head neurointerventionalists that actually has some expertise in maternal strokes and is going to provide some information to you. I'm going to go ahead and load up his presentation and let him tell you more and get started. Yeah, that's right. Move it. So, I bet it'll work. Yep. Okay.
Good afternoon. Thank you very much for the invitation. It is a pleasure to be here. We should be discussing, I think, pregnancy and stroke. I was communicated about this yesterday, and I put together the slides, and hopefully I'll illustrate a little bit about the stroke side of the equation. I am a stroke and endovascular physician. I mostly work in doing neurointervention. My stroke days are kind of over at this point, but I still deal with strokes indirectly. So I have no disclosures besides the fact that I was on call and I was at Grady overnight, and I'm under a lot of influence of a lot of coffee. So we will be discussing strokes. I just want to set some things straight. Stroke is basically a term that encompasses hemorrhagic and ischemic disease. Hemorrhagic disease is when there is blood that comes off of the blood vessel. And ischemic disease is when there is insufficient blood flow to a certain area of the brain, and it can lead to ischemia, which is basically suffocation of the brain cells, and then infarct, which is when the brain cells die. So we'll be talking about both. Both are related to pregnancy in certain ways. So the incidence of stroke in pregnancy seems to be increasing. There's a lot of data. I wrote a chapter on this 8 years ago, but some data have accrued since then. But this study was interesting. It's a national inpatient sample data. It's basically an all-payer database that people can do research through. And if you compare the period from 94, 95 to 2006 and 7, you can see that the antenatal and postpartum hospitalizations for stroke increased very dramatically in relative terms, 47 and 83% respectively. And when you compare the rate of strokes between childbearing age non-pregnant females and pregnant females, you see in the slides there that the rate in pregnancy is a lot higher. So it seems really that the stroke rate is increasing and pregnancy predisposes people to strokes. And once again, strokes can be hemorrhagic or ischemic. And I thought this was important to convey here, is that although a small percentage of females that are pregnant actually end up suffering a stroke, it accounts for 12% of maternal deaths and contributes obviously to a significant impact on the quality of the life of the fetus and baby. So we'll be discussing a few specific entities. I think I just want to shed some light on this because I think it illustrates well what the problems are. So aneurysms are basically this blisters of the blood vessel wall. They are acquired lesions, which is very important, and it's typically related to hemodynamic stress. I'm not sure if the videos are going to play. Let's see. Yeah, they're not going to play. But basically, it actually is common, and they develop over time, and it has been reported in 2 to 3% of the population. So it's common that females that are pregnant end up having aneurysms, and sometimes we detect those before pregnancy, and sometimes we can address them. It's basically just a weak spot, as you can see in that slide. The vessel wall of the brain has multiple layers, and there is a weak spot that sometimes is developed over time that allows the formation of those blisters. And those blisters are basically, and it's too bad that I can't play the video because it would show an aneurysm bursting, which was very representative, but basically it ruptures and it floods the brain with blood, and that's very catastrophic from the neurological standpoint. Half of the people die, 25% people die, and then another 50% are disabled, and only 25% are actually independent later on. And obviously, if you're pregnant on top of this, it just makes things more difficult. So the plasma volume increases, and this is applicable to all the stroke subtypes. It probably reaches a plateau in the 3rd trimester. And evidently, if you have a little blister and if you have more blood flow circulating, you have more hemodynamic stress, and there's a tendency that these aneurysms may bleed, typically later on in pregnancy. It could also happen to bleed after pregnancy as well. And if you have preeclampsia and all those things that we discussed today, that just increases the risks. And for aneurysms, the postpartum period doesn't really matter that much, but I just want to basically mention that the body is trying to get ready for delivery, and obviously you need to have the coagulation system adjusted because otherwise the mother would exsanguinate. So you need to have the ability to clot to prevent bleeding after the baby is delivered. So that predisposes to some clotting problems that we'll discuss in a second. But basically subarachnoid hemorrhage, which is when the aneurysms burst, which is this catastrophic neurological condition, is 5 times more frequent in pregnant ladies as compared to non-pregnant females. And as we discussed, rupture risk increases as the volemia, or the amount of blood, starts circulating in the body. And sometimes we can treat them before pregnancy, but unfortunately they bleed sometimes during pregnancy, and we need to deal with them. We can clip, which is just putting the little clip there. We can coil. This is just an example. We put a little microcatheter. This is what I do. Sometimes you can put a little balloon to adjust the neck. As you can see in this picture, there's a little blister at the top of the basilar artery in there, and we can use a balloon to put the coils inside. There's some other fancy things that I wanted to go over, but the videos are not going to work. So we have evolved substantially in the way that we can treat and prevent this of bursting during pregnancy, or to treat them if they end up bursting during pregnancy. So this is just an example of a new device that we have. This is a very large aneurysm, as you can see. You can see the stent shade in there, and then that massive ball just basically goes away.
We know that one of their pregnant ladies had an aneurysm when you said you could treat them before.
Yeah, it's good point. Typically they're asymptomatic, and that's the problem. But the most common symptom once it occurs is headaches. Typically, physicians are relatively aware of the fact that there are some red flags for headaches. So if you're older and you've developed headaches, that's a problem. But typically, pregnant females are younger. So a change in the pattern of headache, or a headache that is typically fixed unilateral, for example, migraines alternate sides. So there are some red flags that clinically can help people to maybe say that there's a secondary reason for the headache and not just a primary headache like tension or migraines. But it is a very difficult topic. So sometimes it's worthwhile for primary care physicians and OB/GYN doctors to get scans or referrals to neurology to have the headaches evaluated. And absolutely, if there is an aneurysm that is detected pre-pregnancy, then it can be addressed. But the issue is that typically they get to these patients after they're already pregnant, and we typically don't do angiograms and studies while they're pregnant. We just try to control the blood pressure to prevent it of bursting. And there are many things that lead to the aneurysm formation, typically high blood pressure and smoking, and all those things need to be addressed in primary care and OB/GYN, let's say prenatal care. Yeah. So it is a difficult problem to detect, but once it happens, we can treat them and hopefully have a good outcome. But it just highlights the importance of the comorbidities, which I'll get to in a second, that are the common denominator of all these conditions that I'll be discussing today. So arteriovenous malformations is basically a shunt between the artery and the vein. The artery has high pressure, the vein has low pressure. And typically, as the vessels branch out, you start losing pressure progressively, and then these little arteries that become very small start merging and forming the veins, and this process is very smooth. But if there is a shunt, as you can see here, with a tangle of abnormal blood vessels called arteriovenous malformation, you expose the veins to high pressures, and sometimes that can burst. So it's pretty much the exact same problem as the aneurysms. Is a vascular lesion that predisposes to rupture during pregnancy. You can also have headaches, as we just discussed for aneurysms. You can have seizures, and all those things are unfortunately less common because these lesions are typically asymptomatic. But if there are red flags, imaging should be performed prenatal, ideally, or during pregnancy, so plans can be made in terms of delivery options, like C-section versus normal delivery, and etc. I just wanted to show this case. It illustrates how difficult it is. 27 years old, developed headaches. I was called when I was off, and I scheduled an appointment for my clinic. She was at 26 weeks. She had this abnormal non-contrast CT. As you can see, a little bit of an abnormality in the right upper corner. So it was an arteriovenous malformation. So she came to clinic. We spent an hour and a half to 2 hours talking, and she was there with her husband and her parents. And I told them that nothing should be done because she was pregnant, and we didn't want to run any risks. Typically, these lesions don't burst, but unfortunately, a few weeks later, they called me again saying that she had bled. So she comes super affected neurologically. As you can see, there's a lot of white, which is the blood inside of the brain. These are the angiographic pictures, but basically she had this little blister that I'll show you there. Right, I'm sorry that the screen is not larger, but there's a little black ball on the right upper corner. Yeah. And we're able to go there and block that, and she ended up recovering well, and she delivered well, and and gladly the baby is doing fine and she recovered completely. Those switching gears to ischemic disease, which is when you have insufficient blood flow. The vessels that bring blood flow to the brain are the arteries, and the ones that actually remove the brain blood is the vein. And the veins coalesce into these big pipes that you can see in blue. And sometimes in the postpartum period, as we discussed, people are procoagulant, so they tend to clot more. And there's big sinuses that drain all the venous blood that is trying to come off the brain, gets clogged. As you can imagine, there's some congestion, right? Hydraulically, that is not good. And because there's congestion, you can have ischemia and suffocation of brain cells because of insufficient blood flow. And you can also stress the veins and they burst. So both things can happen. And it's very common to have this in the postpartum period. Actually, 80% of the CVTs happen in the postpartum period, which is cerebrovenous thrombosis, and is a typically very dangerous type of problem. You can have neurologic findings, and again, is a catastrophic event typically. So once the symptoms occur, it's already too late for us to prevent anything, so we just need to treat with blood thinners. And sometimes we can do these procedures, like this one that I'm showing you right here in this 45-year-old that had this bleeding on the right side, as you can see, all that white again within the brain. You can see that there's this blue here, and there's a missing gap there. So we go there and remove the clot, which is demonstrated there with these devices, and we can restore blood flow and help patients to recover better. So that's a hemorrhagic manifestation. Sometimes you can have infarcts or again, suffocation of the brain cells. And then finally,
when this happens in postpartum, is there a range of time it's most likely to happen? Within a period of time?
Yeah, I think it's the postpartum period, I think, is 6 weeks, and it's typically within the first few weeks of those 6 weeks, as per my understanding. And once again, people are already home, and people just come with severe neurologic symptoms, and we're just trying to catch up with the problems that had accumulated, typically due to either bad luck or bad prenatal care. So arterial strokes are when there is a clot typically that blocks the arteries that are trying to feed the brain with blood flow. Sometimes clots can be small, sometimes it's not even clots, it's like pieces of the placenta, or it can be other things, but most of the times it's clots. And can happen in the third trimester or postpartum period as well. And once the clots are bigger, obviously it causes bigger problems. I had another video that was very helpful. Unfortunately, I won't be able to show. But basically, we can go with this retrievable stents and remove the entire clot. We pioneered this technology at Grady. We participated in the trials that validated this treatment modality. That actually made a very dramatic impact on the outcomes of folks with this larger clots. And sometimes they end up being pregnant females, which is a problem. So this is another example, a 39-year-old lady that was 2 months pregnant. She unusually presented very early on during pregnancy. And as you can see here, this white is the stroke that she had by the time she got to Grady. And because she didn't have a last known normal, right? Sometimes we know when the onset of symptoms occurred, and if it's within a short time frame, we can give this medication to try to dissolve the clot. But sometimes we just don't know when the onset of symptoms was, so we're afraid of giving this strong blood thinners that dissolve the clot. So we need to do mechanical approaches like these procedures that I was just telling you about to remove the clot. And until 2018, people with strokes of this type, the worst strokes, beyond 6 hours, there was no evidence that actually to prove that this was something that would help people. And my partner, Raul Nogueira, is a visionary, and he actually ran this study, which was a global study that was published in 2018 that extended the time window for treatment of strokes up to 24 hours. Oh. So once you say we can treat people up to 24 hours, and until very recently was 3 hours, it's because of the work that was pioneered by my colleague at Grady, which is amazingly nice to hear. But the fact is that she came with this clot that was sitting down in the left side, exposing her entire left hemisphere to the risk of brain death. So all that yellow, as you can see on the screen, was at risk, and only that was actually already dead. So we wanted to save that. And you can see here is a frontal view on the left. There's a blockage where that arrow is pointing to. because of the presence of the clot. And just making the long story short, we restore that with this passes of this retrievable stent. And you can see here the pre-treatment and the post-treatment magnetic resonance imaging that shows the stroke in white is unchanged. So we basically saved all that yellow that was going to die, and she was able to hold her baby with the arm that was previously paralyzed. So just to conclude now, again, it seems that the stroke incidence is increasing, just going back to that same study that I mentioned originally. And the important part here is that it's very common to have concomitant diseases, more commonly high blood pressure, that leads to coronary disease, right heart disease, and leads to cerebrovascular disease as well. And in this study is very interesting that they realized that the stroke rates were going up, but the hypertension and heart disease was also going up. And when we make statistical adjustments to see if the stroke increase was due to just the fact that stroke was increasing, or if it was mostly related to high blood pressure and underlying heart disease, which is typically manifested by also smoking and diabetes, this increase in stroke was actually dissipated, this effect. So it seems that stroke is increasing, but again, population is increasing, so it's not that people are getting sicker. But the fact is that most of it seems to be related to high blood pressure and heart disease, which is again correlated with diabetes and smoking and etc. So in the conclusion, prenatal care and OB, prenatal care and primary care are just critical to improve maternal outcomes indirectly. And once strokes occur, either if it's related to hemorrhage or to ischemia, we can do a lot of things to improve the maternal and fetal outcomes. And this is typically more centralized, right, in bigger comprehensive stroke centers. And it seems that resources are needed, everywhere, probably predominantly in primary care or prenatal care, but also for the treatment of these complications that impact so much the chances of recovery of the mothers. And I think that was it. Thank you.
I here again, if women are listening, we probably will have less babies with all the complications of pregnancy. It's pretty overwhelming. I guess Dr. Ray teaches at the medical school in Augusta, and how many of our OBGYNs, is this stress the importance of people at a high risk? It almost seems like they all need to go to a cardiologist for a review early on in the pregnancy. Our OBs, I think we might have a lack of knowledge in some of our older OBs out in the field about the changes and the need for this cardiology, but what about the medical students? How is it changing?
Well, I think the difficulty is that, one, we know that as a population we're getting sicker, we know we're seeing more comorbidity, but I think the bigger issue is the overlap in what is, the differences between physiologic and pathologic and how they blur, especially in pregnancy. We get alarm fatigue from headaches in pregnancy. Headaches, sometimes it's just a headache, and sometimes it's severe preeclampsia or preeclampsia that is, manifests as some further disease. And then stroke is something we're going to think about a lot less because it occurs at a lot less rate. And I think the key is the education. There is plenty of evidence to tell us that when you take the patient and you risk stratify them, that you're more likely to believe and to then work up their complaint. And in patients that have clear risk factors like hypertension and they're smokers and they have diabetes and have more risk for stroke or any cardiovascular type disease, you should think that it could be something way worse than just their tension headache. And I think that education is a big piece of it, using algorithms, risk stratification for patients, and having access to the care. There is a rich telestroke community, at least in Georgia. I know the dean of our own medical school, was part of this from 15 years ago. So I think that we have a real opportunity, but not unless someone's thinking about it, because I'd rather know it ahead of time than you have to fix it postpartum.
Right. And Grady has it where if somebody does a CT scan out in a rural area of Georgia, don't y'all have an ability to look at those right away? And
Yes, the stroke side, which is generally completely independent from pregnancy, but in terms of stroke care, we have a network of, I think, 80 something hospitals, and we have this shared imaging system in which if there's any question from any ED department, they will just push the images through. And nowadays I receive it on my phone,
Right.
so I can just review it immediately. So they call me, I'll just stop my car and review the images and give recommendations. So I think from that standpoint, we're exemplary in the state in terms of the community mission that we provide. The problem here is that it's really a spectrum, right? Is, you know, if you get to pregnancy with cholesterol build up in your arteries, you already have a higher risk for a stroke, and even if you do great prenatal care, you may still be at increased risk. So, you know, pregnancy, although these people are young, they accumulate a lot of disease very early on, and you know, African Americans have more. It seems that they're more affected by, you know, bad maternal outcomes due to probably higher chances of or higher comorbidities and et cetera. So that's something that we see a lot here in downtown. But the truth is that you accumulate disease very early on, then prenatal care needs to be optimized. I completely agree that risk stratification is probably the way to go. I don't know much about the specs of how it would look like, but yes, education is critical. You know, if there's any high risk features clinically, things should be approached appropriately. And then if there is any complication, right, we need to be able to treat these people the best way possible. So it is a spectrum, unfortunately. I don't think I can pinpoint anything. But yes, I think education is the greatest piece, and hopefully with this effort, we would learn more. One thing that Mike Franco, who is the chief for the Marcus Stroke Center, mentioned is that stroke is not really a reportable disease. I didn't know that until this morning. And apparently cancer is, so maybe that's something that we should be looking into. He has generated the Coverdale Stroke Registry, which is something really spectacular for the state of Georgia. I'm not really that familiar with it, but it's not really a surveillance program. It's more, it's just a registry. But you know, we need to learn more. You know, what is the gap? I think education is a great piece of it. But you know, there are some things that maybe can be done. Maybe this should be a reportable disease, and we'll learn more, because again, it contributes substantially to the poor outcomes that mothers have actually.
Okay. Dr. Ray, you had another one?
Two quick comments. Number one is when we're talking about maternal mortality, we're talking about ultimately small numbers that have huge impact.
Right.
So when you're talking about we still today, despite going through a maternal mortality review committee, will have patients that we have no clear understanding of why they died. And in any state where the system allows for there to be women who do not have a postmortem examination, we often will miss the stroke. So it's if it is someone dies, whether it's a cardiovascular disease, whether it's related to arrhythmia or stroke, without the postmortem examination, we won't know that. And that every number is important when you're talking about small numbers. And number two, I also don't have any clue, despite being what I think is an expert in this area, about the true incidence of stroke, because I often don't know as an obstetrician gynecologist in this state, or probably in any state, because it's not reported. And this falls under severe morbidity, because more often than not, we don't have a maternal death. We have some disability that's related to it that may or may not be permanent. So I think that reporting is a great idea, at least.
Should be on there. Dr. Ellis?
And I practice at Grady too, and did my high-risk OB clinic this morning before coming here. I saw 2 patients complaining of headaches, and that's sort of every OB's, what do I do with this? But both of these patients told me that the headaches were different, and I am married to a neurologist, and he said if the character is different, you need to think about head imaging. So I sent both patients up to labor and delivery, and I think it's important that as OBs, or maternal fetal medicine in my case, that we remind our colleagues in neurology and cardiology that we have to take those complaints differently. I mean, I send them up for a neurology consult. Sometimes it takes a while to get, or sometimes they're available right away, or sometimes we're told, you know, maybe this is not something we need to see. We'll see you as an outpatient. So we've tried to do some on-the-spot education with our neurology colleagues, and the same thing is true with cardiology. I mean, Dr. Ray and I are on the Maternal Mortality Review Committee, and we've seen cases where women would present to ERs, particularly with complaints of chest pains or headaches, and just to be told, oh, you just had a baby, of course you're tired, of course your head hurts, you got a crying baby. And I think we have a lot of education to do for our colleagues that are not OBs or MFMs to make them aware of taking these complaints seriously. Most of the time they won't amount to anything, but you're going to pick up that one or two complaints that do make a difference, and you may save a life. So I appreciate the work of my colleagues at Grady.
Thank you.
Thank you. That's all the questions. And once again, thank you very
Appreciate it.
much
Thank you
for
very much.
coming and doing this at the last minute. And last but not least, Mr. Setish, did I get it right? And I think this is a company that has a new piece of surgical equipment that might be used by more hospitals in the future to help us with one
Thank you.
area of this on hemorrhage. And not pushing your company, but, just an educational opportunity, all right. And glad to know that we have medical, innovation that's coming to help with this issue.
Yeah, thank you, Madam Chair and members of the committee. It's an honor to be here on behalf of my team to speak with you and to give you an update on this technology and to speak about technology in general as a category of solutions that are very actionable in the near term. My name is Siddharth Satish. I'm the founder and chief executive officer of Gauss Surgical. We are based in the Silicon Valley, and the company's been around for several years, and most recently we've been bringing this technology to patients, specifically in obstetrics, as really an area of focus. A bit of introduction here. We're really focused on hemorrhage. Hemorrhage, as you know, is the leading preventable cause of maternal death. The statistics are vast. 70% of hemorrhage-related deaths are really known as preventable. And one of the core factors that we honed in on was that visually estimated surgical blood loss or obstetrical bleeding is highly inaccurate. Vital sign changes are delayed indicators, and hemoglobin and hematocrit are significantly confounded by fluid shifts and intravascular hemodilution during surgery. Specifically, hemoglobin is a measure of concentration, not volume. And so, when a patient's receiving fluid during a case, and it's a very dynamic setting, it's nearly impossible to really tell what the patient's volemic status is. Are they really hemorrhaging based on an abnormally low crit, devoid of some of these other measures? There's been a lot of work done on this, and I'm obviously preaching to the choir. It's really great to see your leadership in this area and focus. Groups like ACOG, A1, CMQCC, as we heard earlier, they have led efforts in this space for many years, and most of these organizations have really recommended formally that we must quantify, not estimate, blood loss at delivery. And this is, we actually saw in the state of Illinois, the DPH had a regulatory mandate a couple of years ago that really pushed for this to be done on every patient who's delivering. Most recently, the Joint Commission announced a new set of perinatal safety standards that specifically call for the use of, and I quote, an evidence-based tool that includes an algorithm for identification and treatment of hemorrhage. I was just reading more about this yesterday, and I saw a statistic that about 51% of maternal death and severe morbidity cases reported to the Joint Commission between 2010 and 2019, so pretty up to date, listed maternal hemorrhage as a contributing factor. So this is just a little bit of background and context. Now, it turns out there are life-saving medications, treatments. We heard about hemorrhage carts earlier that can be enacted as interventions in the context of a hemorrhage. But as you can see, and this is actually the CMQCC protocol, one of the most widely used and adopted protocols available, the central tenet of this protocol, really the linchpin of the protocol, is an ongoing cumulative blood loss evaluation. It plays sort of a diagnostic function, and then you sort of have this map of interventions that can be enacted based on and defined by levels of bleeding. The only problem is we don't really know how to measure bleeding. We don't know how to really do it in an accurate way that's actionable as bleeding occurs. So I want to just show you a little example here. So these are 2 suction canisters that contain blood, and they both have approximately the same volume. The only issue is that they don't actually have the same amount of blood. It's not all blood. So when we typically ask providers to estimate what the blood volumes are here, you kind of get this pause, and typically we say, well, the canister on the right has more bleeding. But it turns out that in this example, the canister on the right has 10 times as much blood as the canister on the left. And so if this is a canister that you might see in the middle of a delivery or a surgery where a patient's bleeding, it becomes very difficult to... thank you for that, great sound effects. That's kind of what you hear is it becomes very difficult to really tell. Just we're limited by our own visual acuity, which canister is really more bloody and how much blood has this patient truly lost when it counts. And so hospitals across the nation have been talking about this. There's actually a word for it. It's called QBL, or quantified blood loss. But hospitals have expressed and experienced many challenges in doing this, specifically in compliance. The whole goal of quantifying blood loss is that we do this on every patient every time, because the goal is for us to, see the onset of a hemorrhage and be able to intervene in time. But there was a study, and this is, a couple of years old, or a few years old. It, I think, is published in 2016 by Dr. Bingham and colleagues from A1. It was a study focused on New Jersey and Georgia, and just at a high level, the compliance with quantifying blood loss, so we've already been trying this for many years, was very low. It was 8% of hospitals for C-sections and 11.6% of hospitals for vaginal birth. So the way that we try to quantify blood loss today, which is to try and collect these sopping wet sponges and weigh them on the baby scale and really try and figure out the checklist and do the math, it doesn't scale very well to this concept of using this in a standardized fashion on every delivery. And so that's where technology, we believe, can play a role. And again, as an example, I'd like to show as a case study the technology that we've built over the past few years at Gauss. This is a mobile app. It's called Triton, and it uses artificial intelligence on the iPad to monitor bleeding in real time and with a high level of accuracy. There's over 1.1 million apps on the App Store that we all use today with these ubiquitous mobile devices. We were pleased to have Apple actually put us on stage at one of their big conferences just last year and featured this as one of the top 10 apps out of the 1 million+ apps on the App Store. And so briefly, how does it work? This is how it works. We use this during the process of a surgery or a delivery to take quick and rapid scans of these blood-soaked sponges or bloody canisters. And we use computer vision and machine learning algorithms, sort of like facial recognition software, to accurately quantify the hemoglobin level on every single pixel. And by doing that, we can effectively calculate and track bleeding in real time as a delivery progresses, and then into postpartum and recovery and postpartum. There's a similar technology. It's also an app for the suction canisters, so you can sort of really track a patient's bleeding as it happens during these critical phases. So here's a very, it looks like our video is not playing. We do have a live demonstration here, not real blood, of course, at the end here. And my colleague, Nikki Woodleaf, has the device, and we would love to sort of show you the demonstration. So what is the point of using this type of photometric technology? The point is that we can watch bleeding in real time, sort of as it happens. And so this is a plot of a very high blood loss C-section case. This was a real case. Every dot on this plot shows you the QBL as the surgery progressed. And what we can see is that you can almost effectively, in a semi-real-time manner, track the cumulative bleeding as it goes past a stage 1 into a stage 2 into a stage 3 hemorrhage. And, Madam Chair, you had asked a previous speaker about, as a hemorrhage is happening, is there a way to sort of say, okay, 1, 2, 3, what stage are you at and how do you act? And that's exactly where we think this type of technology allows us to enable this in practice. And it is doing so today in many, many deliveries. Let's quickly talk about the accuracy. This is the most accurate way that we have been able to come up with so far. As you can see in this study, the visual estimates of blood loss are very inaccurate. These are 3 plots of ways of estimating bleeding. There's the visual estimate. There's the gravimetric method, which I discussed earlier, where we're trying to, weigh things and subtract the amniotic fluid and subtract the dry weights. And then you have this photometric approach, this technology on the right-hand side. And the x-axis, or the gold standard, represents a hemoglobin assay performed after collecting all of these substrates and putting them through a laboratory process. So as close to a gold standard as you can find. And what we found was that, visual estimates of blood loss are always 800 or 1,000 cc's. It's a fait accompli. That's what we're trained to call either not a hemorrhage or hemorrhage, so you see straight lines. The gravimetric method, ironically, is actually worse than visual estimation because of all these other confounding fluids. And we've seen this, time after time in many published studies. Sometimes we get negative numbers because we over-account for how many sponges were used. I see some of the folks on the committee nodding their heads from clinical experience. The Triton system takes a photometric approach, right? So this app is really looking at the color of the hemoglobin, which is what allows us to get diagnostic levels of accuracy. But we didn't stop there. We really sort of heard what our customers and our partners were saying. It's one thing to measure bleeding as it happens in real time, but how can we truly take technology today and put it into place where it can drive hemorrhage care? And so we recently announced the launch of what we're calling as Triton QBL. And this powers a hospital's hemorrhage protocol. It connects to the same technology, either photometric or weight-based, that we currently have in our system. But what it also does is it starts pulling up the hemorrhage protocol as the labor progresses into different stages of bleeding. So when you get to a stage 2, the stage 2 protocol comes up. It's sort of like GPS, right? Instead of using a compass to navigate, your apps now, they tell you, turn right in 100 feet. And we think that this kind of real-time guidance, when paired with a delivery or put on top of a hemorrhage cart, can really start to impact care. It's also on a mobile device now. So we've now made this cross-platform. The application doesn't have to be on an iPod. It can go, or an iPad, sorry. It can go on a handheld iPhone. And it turns out that hospitals have adopted millions of iPhones already for enterprise usage for HIPAA-compliant text messaging and Epic and EHRs. And so we really think taking this sort of software and using it in such a ubiquitous manner can truly make this possible and actionable for every mom who's delivering. So let me briefly step back and give you sort of the update on where we are from a traction perspective. In the past 18 months, we've been fortunate to scale this technology to over 75 hospitals around the U.S. We're now, as of today, performing more than 250,000 deliveries nationwide with this technology. That's, it's a fair amount in a very short time, but obviously there are a lot more deliveries that we would like to see this technology having an impact on. And this is really a chart of our utilization. We track this data in real time, and so we've really found that the technology can scale well given the confines of a busy surgical operating room or a delivery setting. We've also had leading health systems around the country adopt this technology for their surgical safety initiatives and their obstetrical safety. Hospitals like Brigham and Women's, Mount Sinai, and I'll share a few studies in a moment here that really speak to the outcome differences that are coming forth as a result of the implementation of this technology. Those benefits we found fall into 3 major buckets. The first one, which is really key, is early and accurate recognition of hemorrhage. Part of the issue here is we don't know when someone's hemorrhaging truly, and what this technology does is enable early and real-time intervention by leveraging diagnostic data to get to an answer of is there a hemorrhage or not. We've also seen some benefits that really underlie the fiscal and financial return for the hospital in adopting this type of technology with respect to transfusions, length of stay, and ICU admissions, all drivers of significant morbidity and cost. There are over 15 peer-reviewed publications in the medical literature. We just had a really great independent trial published in the Gray Journal from the team at UTMB in Texas. I wanted to briefly end by sharing 3 key studies with you that I think really highlight what this technology is doing today in hospitals around the country. UC Irvine adopted the Triton technology in their burn center. Ironically, it's burns. It's sort of a very a big and bloody sort of case. It almost mimics the worst kind of C-sections you might see. And this is really where this technology was initially validated. What the researchers at UCI found was that by using this technology to track bleeding in real time as the surgery was happening, they were able to more rationally enable transfusion decisions. They saw a drop in their post-operative or so-called catch-up transfusions, a very significant difference. They found that when they transfused patients, they actually received less blood. And they found that the multiplicity of transfusions dropped. So if we wanted to land the plane, we hit the runway and landed it with one transfusion as opposed to playing catch-up with multiple shots on goal. Moving over to the obstetrical space, one of our biggest studies that is published to date came out of Hackensack Meridian Health a couple of years ago. When they implemented this technology, they found that their detection of hemorrhage increased 432%. We were simply missing them by really underestimating bleeding and then treating the signs and symptoms later when those really appeared. But the whole point here is to have early intervention for a hemorrhage. And then this actually led to some downstream indicators that included a reduction in transfusion dose. It turns out when we can catch these hemorrhages, we don't end up with these sort of train wreck cases where there's excessive hemodilution, the patient's now receiving multiple transfusions. So we found that transfusions actually dropped, and there was also a statistically significant association with length of stay greater than 4 days. Most recently, we had a massive study that came out of Mount Sinai, New York. This was an independent 7,600 patient study where they looked at the adoption of this technology as part of their hemorrhage protocol. And what the researchers at Sinai reported was a 340% increase in detection of hemorrhage, a 34% reduction in delayed interventions. And this was, again, across both vaginal birth and C-sections. And they actually self-reported a significant financial return on this technology. So we found that this is truly scalable from a fiscal standpoint. It's not cost prohibitive, which is something we need to think about in the constellation of interventions that can be levered into health systems. And lastly, I'll leave you on this study. Very recently, I alluded to it earlier, an independent 250-patient trial coming out of UTMB Health and published in the American Journal of Obstetrics and Gynecology, also known as the Gray Journal. In this study, we really looked at those higher blood loss cases. Can this truly have any predictive power in true hemorrhages? And what the researchers found was that Triton was significantly a better predictor of hemoglobin drops greater than 2 grams per deciliter. I know that seems very complicated for some folks, but what it basically means is that when the hemoglobin really tanked because patient bled a lot, this technology had a very strong association with that, with a very significant ROC curve. And so that really indicates that by tracking bleeding during a case using technology, we can sort of predict when that patient is going to end up needing some kind of intervention. There's some face validity to that concept. In conclusion, I know that the committee, again, thank you for the opportunity to present this technology to you. And our primary goal here is to build awareness that technology and these new buzzwords like mobile and AI, which we're all talking about, can actually make a material impact in maternal care. I know that the committee will come forward with some recommendations following this hearing. We would like you to consider as one of your recommendations potentially putting in place programs such as an enhanced Medicaid reimbursement. I know you've been talking about Medicaid and pushing for it, so sorry to harp on this, but for labor and delivery cases where technology like this can be used, we think that can truly incentivize the adoption of technology such as this, at scale to really help these patients in these very critical hemorrhages. We also believe, and this came up earlier, that every bundle, every hemorrhage bundle, as we previously discussed, should include critical diagnostic and protocol driving technology. Whether it's this technology or other technology, we think this can really help sort of when the rubber hits the road, we can truly help guide care during these tougher cases. And again, we think that this is very synergistic with the concept of a hemorrhage bundle and a hemorrhage cart. So thank you again for your listening and for having us here.
Do we just individually see when we leave, or?
Bring it up, that's
Yeah.
Okay,
Yeah.
okay.
Happy
Well,
to
I
do that.
have a question, and Dr. Ray will have one, but cost is always a factor. I mean, I'm sitting here thinking about the small hospitals where they don't have a lot of things going on, but is it cost prohibitive for a system?
Yeah, we believe it is not. So we have, over the course of the past 2 years, had the privilege of working with a diversity of systems, not just the Mount Sinai's and the Brighams of the world. We have multiple implementations now across massive systems of 50 to 70 hospitals or more, and we have really worked on understanding the economics. So we think there's an ROI, but we've also designed it such that it's not at all cost prohibitive to adopt this for every delivery.
Okay. Dr. Ray?
So a couple of things. One, I certainly appreciate the technology. It is truly amazing. As I have looked into, we have QBL in our own hospital that's gravimetric, and I will have cases where I will lose negative amounts of blood, so I do question the data that I'm getting back. Oddly enough, I've seen studies from the 60s and 70s using colorimetric techniques for blood loss. So not new, but what you have is truly novel. So I appreciate that. Are there ongoing? Most of the evidence that's out there, certainly on your website, is retrospective. Some of which is industry sponsored. Doesn't really mean that the data is not good. It just means that it's not gold standard. Blinded prospective clinical trials. Do you have data like that currently? If not, is that ongoing effort taking place?
Sure, great question. We definitely have a number of trials that are either ongoing and a couple have been published. I'd say the recent UTMB study was a prospective study, and there are a couple more that are actually in press as we speak, so they've been accepted for publication. So happy to share that with you and with the committee if appropriate.
I also, from the standpoint of it's definitely relevant. No one should likely mount an argument about the accuracy of our blood loss. But the clinical relevance of it in cases, because most cases do not have a hemorrhage. And you, as a surgeon and someone who operates on sick individuals, I also know the host makes a huge difference. So I can see where this would apply broadly, but I certainly see where it would apply to cases where you expect hemorrhage, cases of placenta accreta spectrum, things like this. And so is because of the fact there is an expense. And when we've looked at it in our own institution, it was cost prohibitive for us. I'll say that. So perhaps future considerations for us would be using technology of this kind, especially when we expect hemorrhage. I always am going to worry about the hemorrhage that I don't expect, because that's going to be the most of the cases. But is there a place for it where you see where there, as cost perhaps changes, where you can use it in cases where you expect to have perhaps more hemorrhage?
Yeah, no, I think that's a fair point. So we've obviously evolved our own thinking about the economics, and we do see this from time to time at institutions. And so we've built in some flexibility to enable that, where an institution doesn't necessarily have to have a unit in every room. They can sort of do so in a selective manner. Now, typically what we find is two things. One is that there are those cases where a patient may hemorrhage and there was no predictor of hemorrhage, in which that supports the use of this sort of in a standardized fashion. And the second sort of thing we've seen is that, especially in the institutions that start with a few units to roll this type of technology out, it ends up spreading across because of the utilization, and because sometimes you have two rooms that may want to use the technology at once. All good things, and I'd say we've worked on building some flexibility into how we think about this, so that we can again make this accessible. The point here is for it to not be prohibitive in a sense. The point is for us to use this on every patient every time, and so we've worked a lot on that, and would be happy to update you.
Okay. All right, we're ready for the.
Would you like me to bring it up there, Madam Chairman?
I don't. Yeah, sure. I don't know how close you have to get.
Yeah, you can
Right
put it,
here.
like, right up by the table. Right here.
Can you see it okay? Are you ready? Sorry to the people in the audience.
All right. So the first thing I'm going to show you is the Triton OR, which will be used in cesarean deliveries. And the biggest point that I can make with this, and making North Carolina a case study, is this saves nurses time. And time, not to be too cliche, is of the essence in the OR, especially when a patient is getting ready to hemorrhage. So what this is doing is it's giving back time. So it's plugged in straight into their sponge counting procedure. So as the lap sponge is being thrown off the sterile field, they simply scan the lap sponge and they put it into their sponge counter bag. So you'll see with this, it's using feature extraction technology. And so what it's doing is it's able to read the blood loss that's on that lap sponge, taking out the factors of saline, taking out the factors of amniotic fluid, but only reading the amount of blood loss. Why is this important? Okay, so in C-sections, a majority of your blood loss is going to be on lap sponges as well as in your suction canisters. And we have seen from the studies that Sid has presented that it's able to reduce blood transfusions. Talking about cost, an average blood transfusion, one bag, is $1,100. So think about that as you're looking at this as a possible recommendation. And in moving forward with that, what it does is it creates an ongoing monitor. So they're able to see the amount of blood loss that's happening in that surgery. What's great about this is as that patient is ticking up from 900, 1,000, and so forth, they're able to power their hemorrhage protocols. So they're able to intervene much sooner to help protect those mothers. Think of this almost like a radar gun, right? With cops who pull over speeders. You're not going to rely on their visual estimation. That would never hold up in a day in court, nor would calculating the distance and the time. What this is doing is if we're able to provide that for our drivers, why can't we provide it to our women in healthcare? So that is the C-section technology. And now what I'll show you is the Triton L&D. So the Triton L&D, what this does is the fluids on lap sponges, on towels, and so forth are sequestered differently. And we were actually asked by nurses, can you develop a technology that can help us with our workflow in vaginal deliveries? So I'm going to join this case. And so this is specifically designed for their, sorry, I need to reset real quick. This is specifically designed for their hospital system. Cone uses this technology, UNC uses this technology, for example, close to you in North Carolina, and their systems look completely different. So what it's asking me is to place the bucket on the scale. We do that, and I'm able to put in underpads, lap sponges, anything like that, put it into the bucket, and it's designed to the materials that they use in the hospital. How is this different than the quantitative blood loss that's being taught today? Imagine towels, lap sponges, underpads, all have their dry weights. Now we're asking our nurses to do math in the middle of a vaginal delivery. So what this is able to do is to be able to help them with their blood loss in a matter of seconds. So we're able to intervene again in vaginal deliveries much sooner. So essentially, when you're looking at these studies, the results outweigh the means of having this technology in your facilities. All right, thank you so much.
Thank you.
Thank you. Yeah,
Any
and I just wanted
questions?
to, oh, sorry, I just want to make one quick point about costs. So as we think about the delivery of the technology, technology evolves very rapidly. And one of the transitions I spoke to earlier was the move to the iPhone, which is, more ubiquitous and handheld device. And so, the form factor of this technology is changing, even more rapidly than we can even demonstrate it. And we're very pleased to share that now this technology runs on the iPhone, so it's not just on a cart-based system. And that does take a lot of the cost out of the adoption of the system. So,
Right. Any questions? No, I think we passed. Thank you very much.
thank you.
Okay, we are adjourned.